The subcommittee will come to order. We'll ask our guests to please take their seats. The chairman has a unanimous consent request that the following documents be entered into the record. Statement of Burke Balch, director of the Robert Powell Center for Medical Ethics of the National Right to Life Committee. Second, a letter from Sandra Snyder, president of American College of Emergency Physicians, to Chairman Pitts, Ranking Member Pallone. Thirdly, a statement of Thayer Phillips, president of Retire Safe. Fourth, a letter from 283 healthcare organizations opposing the Independent Payment Advisory Board. Fifth, statement of Karen Zinka, health educator for Men's Health Network. Sixth, a statement of Richard Waldman, president of American College of Obstetricians and Gynecologists. Seventh, a letter from Tim Lang, chair of the Government Affairs Committee, American College of Rheumatology. Eighth, statement of the American College of Radiology. Ninth, a letter from Cecil Wilson, immediate past president, American Medical Association. 10th, testimony from Bob Blancato, National Association of Nutrition and Aging Services Programs. I think you have copies of these without objection, so ordered. I'll introduce our third panel at this time. Testifying in our third panel are Christopher Davis, who is an analyst on Congress and the legislative process for the Congressional Research Service. David Newman is a specialist in healthcare financing at the Congressional Research Service. Ovik Roy is a healthcare analyst with the firm Monis, Crispy, Hart & Company in New York City. Stuart Gutterman is vice president for payment and system reform, executive director for the Commission on High Performance Health System at the Commonwealth Fund. Judy Fader is professor of public policy at Georgetown University. And Dr. Scott Gottlieb is a practicing physician and is currently a resident fellow in health policy at the American Enterprise Institute. Mr. Davis, you may begin your testimony.
Thank you, Mr. Chairman. Chairman Pitts, Ranking Member Pallone, and members of the subcommittee, on behalf of the Congressional Research Service, I appreciate the opportunity to testify about the fast-track parliamentary procedures relating to the Independent Payment Advisory Board. I'm accompanied today by my CRS colleague, David Newman, who is a specialist in healthcare financing. While I will limit my testimony to the parliamentary aspects of the IPAB, at the request of the subcommittee, David is available to answer questions, if desired, on the healthcare policy aspects of the board. Expedited or fast-track procedures are special parliamentary procedures Congress sometimes adopts to promote timely action on legislation. As the name implies, fast-track procedures differ from the usual procedures of the House and Senate because they generally allow the legislation in question to be considered more quickly and to avoid some of the parliamentary hurdles which face most bills. The Patient Protection and Affordable Care Act established two fast-track procedures related to the IPAB. The first governs consideration of a bill implementing the recommendations of the IPAB related to future rates of Medicare spending. The second procedure governs consideration of a joint resolution discontinuing the automatic implementation of the IPAB's recommendations. I will briefly describe both procedures. As others have testified, under PPACA, the IPAB will, under certain circumstances, propose an implementing bill containing recommendations designed to reduce the rate of Medicare spending growth. The Secretary is to automatically implement these recommendations on August 15th unless legislation is enacted before then, which supersedes the IPAB proposals. The procedures established by PPACA permit Congress to amend the IPAB implementing legislation, but only in a manner that achieves at least the same level of targeted reductions in spending growth as the IPAB plan. The Act bars Congress from changing the IPAB fiscal targets in any other legislation it considers as well, and creates a supermajority vote in the Senate to waive this requirement. PPACA establishes special fast-track procedures governing House and Senate committee consideration and Senate floor consideration of an IPAB implementing bill. Under these procedures, the bill is automatically introduced and referred to the House Committees on Energy and Commerce and Ways and Means, and to the Senate Committee on Finance. Not later than April 1st, each committee may report the bill with committee amendments related to the Medicare program. If a committee has not reported by April 1st, it is discharged. PPACA does not establish special procedures for floor consideration of an IPAB implementing bill in the House. It does for the Senate. PPACA creates an environment for Senate floor consideration of an IPAB implementing bill which is similar to that which exists after the Senate has invoked cloture. There's a maximum of 30 hours of consideration and all amendments must be germane. A final vote on the bill is assured. PPACA establishes a second fast-track procedure governing consideration of a joint resolution discontinuing the automatic implementation process of the IPAB recommendations. Such a joint resolution is in order only in the year 2017, and its consideration is also expedited in committee and on the Senate floor. Passage of a joint resolution discontinuing the automatic IPAB process requires a 3/5 vote of members of both the House and the Senate. Both the IPAB implementing bill and the joint resolution I have described must be signed by the President to become law. Should either measure be vetoed, overriding the veto would require a 2/3 vote in both chambers. The arguable effect of these provisions is to favor the continuation of the IPAB and its recommendations, possibly even in the face of congressional majorities supporting a different policy approach. While the fast-track parliamentary procedures governing consideration of an IPAB implementing bill are expedited, they do not in themselves guarantee that Congress will agree on a bill and present it to the President. Because it is not possible to force the House and Senate to agree on the same bill text, whether Congress can pass an implementing bill which will supersede the recommendations of the IPAB is subject to the deliberative process. Finally, as I detail in my written testimony, questions about certain mechanics of these two fast-track procedures, such as how certain points of order under the Act will be enforced, will likely require clarification by the House and Senate in close consultation with each chamber's parliamentarian. The Congressional Research Service appreciates the opportunity to assist the subcommittee as it examines these matters. My colleague and I are happy to answer any questions you may have.
Chair, thanks, gentlemen. Mr. Newman, you're recognized for 5 minutes for an opening statement.
I have no independent testimony.
Ms. Cohen, I apologize to you. I failed to introduce you in the introduction. Diane Cohen, Senior Attorney for Goldwater Institute. You're recognized for 5 minutes. Welcome.
Thank you. Thank you, Chairman, and thank you, Ranking Member Pallone. I really appreciate the opportunity to come here all the way from Arizona and to discuss with you the unprecedented constitutional issues raised by Congress's establishment of the Independent Payment Advisory Board and the real-world consequences that this unprecedented independent agency will have on the lives of citizens and especially seniors. The Goldwater Institute's legal challenge to the Patient Protection and Affordable Care Act is unique among the lawsuits challenging the Act because ours is the only one that challenges the constitutionality of IPAB. We believe the creation of IPAB represents the most sweeping delegation of congressional authority in history, a delegation that is anathema to our constitutional system of separation of powers and to responsible, accountable, and democratic lawmaking. IPAB is insulated from congressional, presidential, and judicial accountability to a degree never before seen. It is the totality of these factors that insulate IPAB from our nation's system of checks and balances that renders it constitutionally objectionable. Specifically, IPAB is an unelected board of bureaucrats whose proposals can become law without the approval of Congress, without the approval of the President, and they are insulated from rulemaking, administrative and judicial review, and any meaningful congressional oversight. Far from representing Medicare reform, IPAB is an abdication of what has been historically a congressional responsibility. Indeed, it's an unconstitutional delegation of Congress's legislative duties and is unaccountable to the electorate and immune from checks and balances. And I want to just follow up on what the Secretary testified about earlier this morning. Let us be clear, Section E5. The Act specifically prohibits judicial review. And what that means is that the Act prohibits judicial review. If the Secretary acts outside the law, there is no judicial review. There is no accountability for her actions. Secondly, these are not mere proposals or recommendations. These are legislative proposals that can become law. We also heard talk about, well, one provision says there's no judicial review, but we're not supposed to believe that. Another provision says a joint resolution is required to dissolve the board, but we're not supposed to believe that. And then another provision prohibits rationing, but we're supposed to believe that. IPAB is independent in the worst sense of the word. It is independent of Congress, independent of the President, independent of the judiciary, and independent of the will of the American people. Thank you, Mr. Chairman.
Chair thanks the gentlelady and recognizes Dr. Fader for 5 minutes.
Thank you, Chairman Pitts. Ranking Member Pallone, members of the committee.
You pull your mic or push it on. Yeah.
Better. That okay?
That's better.
There. I'll start again. Chairman Pitts, Ranking Member Pallone, members of the committee, I'm glad to be with you this morning as you consider the role of the Independent Payment Advisory Board established by the Affordable Care Act. I'd like to start in thinking about how to approach that by calling your attention to the fact that Medicare is an enormously successful program, more successful than private health insurance in pooling risk and controlling costs. Medicare has historically achieved slower spending growth than private insurance, and the ACA extends its relative advantage. Action taken in the Affordable Care Act achieves an average annual growth rate of 2.8% per Medicare beneficiary for 2010 to 2021, 3 percentage points slower than per capita national health spending. National health spending is projected to grow faster than GDP growth per capita by close to 2 percentage points. But Medicare's projected per beneficiary spending growth will be a full percentage point below growth in per capita GDP. Growing slower than the private sector is good, but not good enough, since both public and private insurers pay too much for too many services and fail to assure efficiently delivered quality care. That's why the Affordable Care Act goes beyond tightening fee-for-service payments to pursue a strategy of payment and delivery reform and creates the IPAB to assure effective results. The strategy includes payment reductions for overpriced or undesirable behavior and bonuses or rewards for good behavior, most especially for payment arrangements that reward providers for coordinated, integrated care efficiently delivered. These reforms have the potential to transform both Medicare and, by partnership and example, the nation's healthcare delivery system to provide better quality care at lower costs. But their achievement and implementation cannot be assumed. That's why the IPAB exists, to recommend ways to achieve specified reductions in Medicare spending by changing payments to healthcare providers. In essence, IPAB serves to inform and assure congressional action to keep Medicare spending under control. Some legislators have proposed to repeal the IPAB, but along with about 100 health policy experts who recently wrote congressional leaders in support of IPAB, I see that effort as sorely misguided. As we wrote, the IPAB enables Congress to mobilize the expertise of professionals to assemble evidence and assure that the Medicare program acts on the lessons of the payment and delivery innovations the Affordable Care Act seeks to promote. I'd contrast the ACA strategy to strengthen Medicare, including with the inclusion of IPAB, with the alternative strategy, not only to repeal IPAB, but also to eliminate Medicare for future beneficiaries, replacing it with vouchers for the purchase of private insurers, vouchers that take advantage of all Medicare payment reductions included in the Affordable Care Act. The Congressional Budget Office analysis shows that such action would not slow health care cost growth. Rather, it would increase insurance costs and shift responsibility for paying most of them onto seniors. doubling out-of-pocket costs for the typical senior 65-year-old, from about $6,000 to $12,000 in 2022, with out-of-pocket spending for beneficiaries growing even further in the future as the gap between Medicare slower cost growth and private insurance faster cost growth would increase. Medicare is clearly given Medicare's track record relative to private insurance in delivering benefits and controlling costs, morphing Medicare into a private insurance market simply makes no sense. Medicare is clearly doing its part to control spending and to bring the rate of spending growth under control. That healthcare spending growth is not fundamentally a Medicare problem, it's a health system problem. Medicare can only go so far on its own to promote efficiencies without partnership with the private sector. Effective payment and delivery reform requires an all-payer partnership to assure that providers actually change their behavior, rather than looking to favor some patients over others or to pit one payer against another. Rather than moving to abandon IPAB, which supports Medicare's continued and improved efficiency, Congress should therefore modify IPAB's current spending target to apply not just to Medicare, but to private insurance, indeed to all healthcare spending, and extend its authorities to trigger recommendations for all payer payment reform if the target is breached. Only payment efficiencies that apply to all payers can assure Medicare and all Americans the affordable quality care we deserve. Thank you, Mr. Chairman.
Chair thanks, gentlelady, and recognizes gentleman Mr. Roy for 5 minutes.
Chairman Pitts, Ranking Member Pallone, and members of the Health Subcommittee.
Is your mic on?
Let's see. There we go. Chairman Pitts, there we go. Ranking Member Pallone, members of the Health Subcommittee, thanks for inviting me to speak with you today about IPAB. My name is Ovik Roy, and I'm a healthcare analyst at Moness, Crespi, Hart & Company, a securities firm in New York. In that capacity, I recommend healthcare investments to our clients who represent the largest investment firms in the world. In addition, I'm a senior fellow in healthcare at the Heartland Institute, in which capacity I conduct research on health policy with an emphasis on entitlement reform. In my remarks today, I'll focus on 4 questions. First, why is Medicare so expensive? Second, what's the best way to adjust the growth of Medicare spending while preserving high-quality care for seniors? Third, is IPAB likely to aid these goals? Fourth, is IPAB perfect as it is? Is it possible to reform or improve IPAB? Or should Congress scratch the whole thing and try something else? Why has Medicare spending gone through the roof? Many trees have been killed in search of answers to the question. But while there are many plausible drivers of Medicare's spending growth, the single biggest problem is this. It's easy to waste other people's money. It's like the difference between a cash bar and an open bar. At a cash bar, I might order a beer or a house wine, but at the open bar, I'd probably ask for a fine Kentucky bourbon, especially if Congressman Guthrie and Whitfield come back. Price becomes no object in such a system, and Medicare is more like that open bar. As a result, seniors tend to be entirely unaware of how expensive their treatments are and have no incentive to avoid unnecessary or overpriced care. Studies show that spending has increased most rapidly in those areas of health care where individuals bore the least responsibility for their own expenses. So what should Congress do? There are 3 ways to deal with the Medicare cost problem. The first, which is what we do now, is to avoid hard choices by promising that we'll cover nearly every treatment, but underpay doctors and hospitals in compensation. The second approach, which we call rationing, is for Medicare to determine, either by congressional order or an expert panel, that certain treatments aren't cost-effective and deny them to seniors who seek them out. The third option would be to let seniors decide by granting them more control over their own health dollars, either by increased cost sharing and or by allowing them to choose between different insurance plans with different benefit packages. Our current approach, underpaying doctors and hospitals, is leading more and more doctors to drop out of Medicare. We already see this problem in Medicaid, where internists are almost 9 times as likely to reject all Medicaid patients for new appointments than those with private insurance. According to Medicare actuary Richard Foster, Medicare reimbursement rates will become worse than those of Medicaid within the next 9 years. And studies show that health outcomes for many Medicaid patients are worse than those who have no insurance at all. As you know, after objections that rationing care through IPAB would resemble a death panel, Congress severely constrained IPAB's authority, preventing the board from including any recommendation to ration care, raise premiums, increase cost sharing, restrict benefits, or alter eligibility requirements. I know that you are all very familiar with the endless tussle over the Medicare Sustainable Growth Rate, or SGR, which has caused significant fiscal headaches because Congress routinely overrides the SGR's requirements for reduced payments to doctors and hospitals. But IPAB, as it's currently designed, is similar to SGR in that its primary approach to cost control involves reducing payments to physicians. These global reimbursement cuts haven't worked in the past, and they won't work in the future. Hence, we should be seriously concerned that IPAB, as it's currently designed, will reduce seniors' access to doctors and healthcare services, thereby worsening the quality and outcome of their care. So the question we must then ponder is, can IPAB be fixed, or should Congress wholly repeal it? It's conceivable that a differently designed IPAB could help Medicare spending more efficient. For example, an IPAB that was empowered to make changes to Medicare premiums, cost-sharing provisions, and eligibility requirements could assist Congress in enacting much-needed reforms to the program. I know that both IPAB's proponents and its opponents see the board as a foot in the door for government rationing. But let's remember that, for 45 years, we've misled the public into thinking that we could provide seniors with unlimited taxpayer-funded health care with no constraints. IPAB, to its credit, is an attempt at intellectual honesty because government rationing is the logical and necessary consequence of single-payer systems like Medicare. Between IPAB and the 2012 House budget, Congress can now have an honest debate. Should we move to a more British-style system of rationing under single-payer health care? Or should we move to a more Swiss-style system of individual choice and diverse options? In the diversity and choice approach, if you don't like how your health plan restrains costs, you can switch to another plan or spend your own money on a more generous plan. In the government-driven approach, you have to accept what the government tells you to accept or pay onerous economic penalties. It's certainly my view that diversity and choice is more appealing and also more likely to work. Thanks again for having me. As an addendum to my written testimony, I've included an article from the latest issue of National Affairs in which I further expand on these issues. I look forward to your questions.
Chair thanks the gentleman and recognizes Dr. Gutterman for 5 minutes.
Thank you, Chairman Pitt, Vice Chairman Burgess, Ranking Member Pallone, and members of the subcommittee for this invitation to testify on the Independent Payment Advisory Board. I'm Stuart Gutterman, Vice President for Payment and System Reform at the Commonwealth Fund, which is a private foundation that aims to promote a high-performance health system that achieves better access, improved quality, and greater efficiency, particularly for society's most vulnerable members, including those with low incomes, the uninsured, young children, and elderly adults. I'm particularly glad to be able to speak to you on this topic because I've been working on Medicare issues, particularly payment policy, for a long time at CMS, MedPAC, and CBO. I've seen the problems faced by the program persist over time despite continuous efforts to address and remediate them. I believe we have an unprecedented opportunity and a historic imperative now to address these problems in a comprehensive way, which is the only way they can be solved. The Congress faces a challenging dilemma in addressing the growth of Medicare spending. Achieving an appropriate balance between controlling costs and continuing to achieve the objectives of the program is a difficult task, but one that is of the utmost importance. An important factor to considering policies to control Medicare and other federal health spending is the fact that it is largely driven by factors that apply across the healthcare system, putting pressure not only on the public sector, including both federal government and state and local governments, but the private sector as well, including both large and small businesses, workers and their families, and others who need or may need health care. Treating healthcare cost growth only as a Medicare issue can lead to inappropriate policies that fail to address the underlying cause of the problem and lead to increasing pressure not only on Medicare and its beneficiaries, but on the rest of the health system and the people it serves. In other words, I guess I'd say that the open bar extends not only to Medicare beneficiaries, but to all patients who make choices about how much health care to use and their providers. The IPAB, if used appropriately, can serve as a helpful tool in attempting to address these issues. It should be viewed as an opportunity to focus the attention of policymakers both in the executive branch and the legislative branch, and in fact of stakeholders in state and local governments and the private sector as well, on action that in the end has to be taken to avoid an alternative that everybody should agree will be unpalatable. I've described some of these actions in my written testimony, which I won't go into detail here. But suffice to say, this will require a broader view of the role of IPAB and all other available mechanisms as well. It's not a question of whether Congress or the IPAB should be trusted to solve this problem, but the issue that it will take collaboration among Congress, the administration, and all parties involved in the healthcare system to solve it. While the board is currently charged with identifying areas of overpayment in Medicare, its scope of authority also includes issuing recommendations for Medicaid and private insurer payment policies. And the combined leverage of multiple payers could, in fact, yield prices closer to competitive market prices, as well as greatly reduce administrative burdens on physician practices and hospitals, all while stimulating delivery system improvement and innovation. To be sure, how much we pay for health care is very important, but how we pay and what we pay for is even more important. The IPAB should be looked at as a tool to be used to improve health system performance in this way. In this regard, an array of payment approaches can be designed to encourage providers to become more accountable for the quality and cost of care beneficiaries receive, and reward them rather than punishing them, as the current system often does, for providing that type of care. In this regard, the IPAB can and should work closely with the new CMS Innovation Center. These innovations should be developed both from the top down, with the federal government leading the way, as well as from the bottom up, with federal government joining in initiatives developed and implemented by local stakeholders. The Affordable Care Act provides for testing innovative payment strategies, including broad authority for the Innovation Center to pilot test a broad array of payment and delivery system reforms. The IPAB should have the flexibility to work with the Innovation Center to quickly adopt and spread successful innovations throughout the Medicare and Medicaid programs, and work to encourage their spread and align improvement efforts throughout the healthcare system. Finally, and perhaps most importantly, the scope of the IPAB should include working with private sector payers on ways to foster collaboration between the public and private initiatives to improve organization and delivery of healthcare and slow cost growth. Given the CBO's finding that 55% of the projected increase in federal health spending over the next 25 years can be attributed to excess growth in healthcare costs throughout the healthcare sector, this problem plagues businesses, households, federal, state, and local government alike, and it seems clear the only way to reduce growth in federal health spending is to address the growth of total health spending. The emphasis, summing up, the emphasis of IPAB as part of a broader process should be on total healthcare costs rather than only federal spending, enhancing access and quality, being sensitive to distributional impact, including protecting the most vulnerable, emphasizing the need to improve performance, encouraging coherence and alignment of incentives across the entire healthcare system. Again, the IPAB can be useful as a vehicle for focusing attention on these most critical issues if all the public and private sector stakeholders can work together to make it so. Thanks for inviting me to participate in this hearing, and I'm honored to be here before the subcommittee and with these distinguished panels, and look forward to the rest of the discussion.
Chair thanks the gentleman and recognizes Dr. Gottlieb for 5 minutes.
IPAB was created based on the premise that decisions about the pricing of Medicare's benefits are simply too contentious to be handled by a political process. But changes to the way Medicare pays for medical services affect too many people in significant ways to be made behind closed doors. How Medicare prices medical products and services has sweeping implications across the entire private market. They are some of the most important policy choices that we make in healthcare. To these ends, there are some considerable shortcomings with the way that IPAB is structured and how it will operate. Among these problems, IPAB has no obligation to engage in public notice and comment that's customary to regulatory agencies whose decisions have similarly broad implications. IPAB's decisions are restricted from judicial review. In creating IPAB, Congress provided affected patients, providers, or product developers with no mechanism for appealing the board's decisions. IPAB's recommendations will be fast-tracked through Congress in a way that provides for only a veneer of congressional review and consent. The cumulative effect of the rules for appointing members to IPAB will almost guarantee that most of its outside members hail from the insular ranks of academia. But most significantly, IPAB is unlikely to take steps that actually improve the quality of medical care and the delivery of services under Medicare. That's because IPAB does not have any practical alternative to simply squeezing prices in the Medicare program. The problem we have in Medicare is a problem with the existing price controls that erode healthcare productivity and Medicare's outdated fee-for-service payment system. This leads to inefficient medical care. There is too little support for better, more innovative ways of delivering health care. So what is IPAB likely to do besides simply squeeze prices? It will also try to confer CMS with new authorities to enable the agency to make more granular decisions about what products and services CMS chooses to cover. IPAB could well confer CMS with constructs such as least costly alternative authority or the authority to consolidate drugs, devices, equipment, and services under the same payment code. The combined effect of these new powers would effectively give CMS the ability to engage in tacit forms of reference pricing. The problem is that CMS has no tradition of making these kinds of decisions. As a consequence, it has little capacity to make the required clinical judgments. I believe many in Congress realize this, and I know many stakeholders recognize it. This isn't just a question of expertise. It's also a question of whether these kinds of personal medical choices should be made in the first place by a remote agency that's far removed from the circumstances that influence clinical decision-making. This will have implications for patients and providers. It will also have implications for those developing new medical technologies, making that process more uncertain, more costly, and less attractive to new investment. Medicare must continue to implement reforms to align its coverage and payment policies with the value delivered to beneficiaries. Congress needs to focus on real ways to get longer-term savings like premium support, modernizing benefits in traditional Medicare, and paying for better outcomes. IPAB makes it even harder to do all these things. In closing, if Congress believes that the political process is incapable of making enduring decisions about the payment of medical benefits, then all of this is an argument for getting the government out of making these kinds of judgments in the first place. It's not an argument for creating an insular panel that's removed from the usual scrutiny to take decisions that other federal entities have failed to adequately discharge precisely because those decisions could not survive public examination. Thank you.
Chair, thanks, gentlemen. I'll now begin the questioning and recognize myself for 5 minutes for that purpose. Mr. Roy, changes that reduce cost by improving the health care delivery system and health outcomes often require several years before savings may occur and the board may have to find immediate savings. Therefore, isn't there a real concern that board proposals may skew towards changes in payments which are likely to result in de facto rationing of care and ignore the more important aspects of long-term reform?
In fact, it appears that that is almost certain to be the likely consequence of IPAB's decisions.
Thank you. Ms. Cohen, can you expand on how difficult it would be for Congress to stop or override the decisions made by the 15 experts on this board once the process is put into motion?
Certainly. Well, first of all, it is not a matter of Congress being able to come up with an alternative. The alternative would actually have to be exactly what IPAB would have already done. They have to make the same costs, or an alternative couldn't even be viable pursuant to the statute. There can be no amendments to the IPAB's proposal, again, unless it meets the very strict requirements of IPAB statute. So basically, Congress can do nothing but do more than what IPAB has done. It certainly couldn't do less. But more than that, we've talked about how about the spending targets, but IPAB's power is much broader than that. IPAB also has powers that could affect the private market, and it's very unclear about if a proposal came from IPAB that included recommendations for the private market, or legislative proposals as they are called in the Act, whether Congress could actually override that. And then, of course, there's the supermajority voting requirement in the Senate, and that, of course, is a very difficult hurdle.
Thank you. Anyone can respond to this question. I have a question. Savings attributable to the IPAB have varied considerably. The CBO scoring for the IPAB has changed several times. Initially, the CBO estimated that savings attributable to the board would be $15.5 billion over the 5-year period from 2015 to 2019. In March 2011, realizing that under current law, the IPAB mechanism will not affect Medicare spending during the 2011-2021 period, CBO scored repeal of the IPAB at 0. In April, using an obscure statistical methodology called the one-sided bet, the CBO revised this estimate again and now says that full repeal of the IPAB would cost $2.4 billion. Can anyone explain why this has been so difficult to score? Mr. Davis, you want to try?
Mr. Chairman, I'd like to, if I can, defer to my colleague.
All right, Mr. Newman.
I think basically we've got a varying set of assumptions going forward, and that these estimates are likely to change in future years too. If Congress fixes the SGR, the baseline estimate with respect to what program expenditures are going to be will change, and once that changes, the targets will change, and the potential savings resulting from board recommendations will change too. I think what you're doing is looking at snapshots of these estimates over time.
All right, thank you. Dr. Gutterman, regarding the IPAB, the CBO stated that the board is likely to focus its recommendations on changes to payment rates or methodologies for services in the fee-for-service sector by non-exempt providers. And the Kaiser Family Foundation recently stated in an issue brief that the one-year scorable savings mandate may discourage the type of longer-term policy change that could be most important for Medicare and the underlying growth in healthcare costs, including delivery system reforms that MedPAC and others have recommended, which are included in the ACA, and which generally require several years to achieve savings. Would you agree with this assessment from both the CBO and Kaiser Foundation?
I would suggest that the IPAB, since it doesn't exist yet, what it focuses on will depend a lot on the environment in which it operates, and I would envision IPAB as working closely with the Innovation Center to incorporate some of the best policies that were enacted in the Affordable Care Act and other policies, other policy ideas as well. I would hope that IPAB wouldn't be an either-or proposition, that you'd either take IPAB or the Congress or some other party, but that it would be people working together to try to find the best policies available to accomplish the goals that IPAB was established for, which is to slow Medicare spending and more broadly to slow healthcare spending.
Chair, thanks. Gentlemen, my time's expired. Okay, Chair recognizes Ms. Shortkowski for 5 minutes for questions.
I thank you, Mr. Chairman and Mr. Pallone, for letting me go out of order. Mr. Roy, I have to say that I am deeply offended by your open bar analogy. It's like saying, oh, honey, now that we're 65, I can get breast cancer and you can have that heart attack. And we are now able to get, I can get a PET scan and an MRI and a CAT scan, as if older Americans are making those kinds of decisions. Or, as I think Dr. Gunderman pointed out, as if they're making those decisions differently from people who have insurance, who also, go about their business knowing that they're insured and get the health care. I mean, really, I think this idea that, and also that Medicare has exploded. It has not, in fact, exploded more than health care costs in the private sector. Is that true, Dr. Fetter?
That is true. That is true, Congresswoman. That Medicare spending per capita grows more slowly than the private sector.
More slowly. The other thing is, you must not have seen the recent Medicaid study, a scientific study done out of Oregon that absolutely showed, the first actual scientific study that was able to take 10,000 people who got Medicaid, 10,000 who did not, and had profound improvements in the health care of people. You ought to check it out. It's a very important important study. So I think that it's insulting to older Americans to say that now they're just spending their days just having a great time at the doctor. Mostly I think people are trying to figure out how to, perhaps have a little vacation or something, or pay for their medications is more likely. Dr. Fetter, what you're saying in your testimony is that because the problem is system-wide, that and you mentioned how consumers should have choices, and mentioned Switzerland. Switzerland says in the basic package, insurance companies can't make any profit. Did you know that?
Yes, they're nonprofit companies.
They're nonprofit companies.
generate
That makes
income.
a rather big difference between the U.S. system that anyone has proposed and the Swiss system, which I think was sort of glossed over in your saying that we should have more. I think I'd like that. That would be just fine. But Dr. Fetter, I want to get back to you and say, so how exactly would that work if we were to bring everyone under the system?
Well, Ms. Schakowsky, as you know, the Independent Payment Advisory Board is now authorized to make recommendations for the private sector, but they are not binding. There's not an overall target. There's a target on Medicare alone. And since, as you say, and I agree, the problem is system-wide, we could modify that target, that authorization, to apply to all of healthcare spending, because Medicare and private spending are driven by the same factors and can be most effective if their payment mechanisms are aligned. And a way to do that is, as the IPAB examines the evidence, as Dr. Goodman said, works with the Innovation Center and looks for ways to improve payment in both the public and private sector. Adoption of those improved payment mechanisms could be recommended to the Congress for application not only to Medicare, but as conditions, we could say, for favorable tax preferences under current law. So we have the capacity to apply these mechanisms across the board.
And there could be some carrots, you pointed out, as well as sticks.
I beg your pardon, there could be?
The carrots as well as sticks.
Absolutely. Yeah. I think what the goal is to change the way in which we pay, consistent with, I believe it was Mr. Murphy was asking the Secretary about coordinating care. The goal is to move away from rewarding providers for delivering ever more and more expensive services toward delivering good care, efficient, higher quality care, coordinated and efficiently delivered, and rewarding providers accordingly.
Okay. Would anybody want to comment on the issue of access to care? Is it really a concern that and I'll leave that to that if Medicare reimbursements are too low as a result of a decision by IPAB, that doctors simply won't take Medicare patients?
That's already happening. So if you look at consistent surveys, the rate of the difficulty for Medicare beneficiaries gaining access to care is higher than it is for people in private insurance.
Actually, I saw an opposite study. Maybe you haven't seen a more recent study that has 93% of Medicare patients were able to access care, as opposed to 88% of people who had private insurance.
The consistent consensus of all the data is that Medicare access to care for Medicare beneficiaries is worse, and I recommend that you talk to the physicians in your district, and I think they'll agree.
I have to take issue with that. That is not consistent evidence. That MedPAC finds that through the surveys that they do, that the access that Medicare beneficiaries have access in the vast majority of communities around the country. There are variations, and that in many respects, if not most, or if not all, the access is superior to those for private insurance.
Thank you. My time has actually run out. I don't know, Mr. Chairman, if Dr. Goodman...
If I can add one more comment, any issues there are with current or future access problems for Medicare beneficiaries probably attributable to the sustainable growth rate mechanism, which is kind of a separate issue from the IPAB. And I'd also point out that CBO's estimate of the impact of the whole Affordable Care Act on Medicare spending was that the projected increase pre the ACA of 94% over the next 10 years would be reduced to an increase of 71% over the next 10 years in Medicare spending. I think that could hardly be described as rationing care or starving providers.
Okay, Chair thanks the gentlelady and recognizes Dr. Burgess for 5 minutes for questions.
Thank you, Mr. Chairman. Let me just say on the issue of access to care, Mr. Roy, I have talked to the doctors in Schakowsky's district, and they tell me to a man and a woman that they are in deep trouble because they cannot afford the cost of delivering their care. Now, true enough, MedPAC came to this panel, I think it was in the last Congress, testified to us that there were not access issues that they had identified, and then Glenn Hackbarth has visited me since then saying he is becoming concerned about people, particularly seniors who move. And when does that happen? Oh, I want to be closer to the grandkids. So they move to a new city or location, and there they find the door is closed. And if this Congress continues to bury its head in the sand about that, we're going to find that the world becomes very, very hostile. Now, Mr. Roy, let me just tell you, I was not offended by your open bar analogy. I do not drink myself, but I thought it was apropos. And, you know, the President of the United States, when he had the Republicans down 3 or 4 or 5 weeks ago to the White House, big reception in the East Room, and he wanted to drive a point home with us. And I think the point he wanted to make was that drugs cost too much. But the point he made was that during the, and it's not a HIPAA violation because he told us in an open forum, in the election, he developed a rash on his back. And he was concerned about it. So we went to a doctor who's prescribed some goop to put on it. And he put the goop, he didn't use the word goop, I made that up. But he put this cream on it for the prescribed time. And it might have helped a little bit, but not so much. So we had it refilled. He had a little prescription card. It cost him $5 to get it refilled. So we went down and had it refilled. And then he was on the campaign trail, and he ran out. So what to do? He went to a pharmacist, explained to the pharmacist his dilemma, got the prescription transferred via the miracle of electronic records, and the pharmacist bagged it up for him and said, that'll be $400. And the president looked at the pharmacist and said, you know, this rash is not that bad. And at that point, the president became an informed consumer and was spending his health care dollars wisely. Now, people do argue that, well, wait a minute, you go into that sort of system and people will not get health care when they need it. He also pointed out to us, and I did not know this, but apparently one of his daughters was gravely ill when she was very young, and he went to the emergency room with her, and the doctor explained the diagnosis and what would have to be done and what he proposed. And the president, then not the president, but he said, do whatever it takes. And of course he did. He behaved in a rational fashion that you would expect, what you would expect a father to do when their child is gravely ill. He did not question cost. So I guess the point I'm trying to make is the president actually articulated a strategy for consumer-directed health care that I thought was phenomenal for him to admit. Now, we had some hearings leading up to the Affordable Care Act. We didn't have hearings that I thought really would have gotten to the issue of the cost of delivering care. If we were serious about that, we should have invited Mitch Daniels in here and said, how did you do it with your Healthy Indiana plan? Now, Dr. Fader is saying that the cost of Medicare grows more slowly than other areas. I don't think that is accurate, and I'd like to hear Dr. Gottlieb or perhaps Ms. Cohen weigh in on that, and you too, Mr. Roy. But we never heard from someone who is actually making it happen on the ground. A Healthy Indiana program cost went down by 11% over 2 years. So even if we accept the figures that I believe are wrong that Dr. Fader is talking about, why wouldn't we do something that's even better than that, which was look into consumer-directed health care? Because, as the president so correctly articulated, something magic happens when people spend their own money. Now we're left with this independent payment advisory board that's going to tell us how to magically spend less money. And it just takes me back to a speech that Ronald Reagan gave in 1964. And he talked then about some of the issues that were ahead and whether or not this country still believes in its capacity for self-government, or whether we abandon the American Revolution and confess that it is a little intellectual elite in a far distant capital that can plan our lives for us better than we can plan them ourselves. Ronald Reagan was describing the Independent Payment Advisory Board. I've gone on too long, but Dr. Gottlieb, do you have an impression as to whether or not the cost of delivering care is rising more slowly in Medicare than in other areas?
Refer to Mr. Roy on analysis and numbers. I haven't seen any apples-to-apples comparisons on senior care because everyone's in Medicare. So
that's correct. So you can't really analyze the numbers directly because seniors, of course, are almost all in Medicare, not all of them. But and they're also over 65, so they have higher medical expenditures.
Well, let me ask you a question. Regardless of whether you're a for-profit or not-for-profit insurance company, you need to have access to capital. So the cost of that capital is what the cost of the capital is on the open market. But does Medicare have a cost of capital that they have to put on their balance sheet?
No, in fact, there are a number.
Do they have a cost for advertising they need to put on their balance sheet?
There are a number of different aspects of Medicare administrative costs that are off the HHS or Medicare.
And on that general administrative side of the balance sheet, what about all of the administration that goes on in the Department of Health and Human Services that is appropriated through a discretionary appropriation, which is the largest appropriation that occurs every year that the Congress deigns to do appropriations bills?
That is
I would just add, the most significant cost of Medicare is the cost of compliance with the Medicare program, which is a cost that isn't estimated. If you look at what goes on in medical practice, a good percentage of the expenditures in any medical practice or in the hospital is on trying to comply with the Medicare program because of the threat of, a Justice Department audit or a Medicare audit. Hospitals, medical practices overspend on that. That doesn't get calculated in the cost of the overall program, if you will. Private health care plans have to actually hire staff to do that kind of work. Medicare can just foist rules on the private sector and back it up with the threat of litigation or criminal penalty, and those costs don't get estimated in the cost of the program.
Very well, thank you.
Roughly speaking, the administrative costs per double when you count all the off-budget expenditures of Medicare, and that doesn't also include the cost of fraud, which is very significant in the Medicare program relative to that for private insurers. If you add all that up, the administrative cost per beneficiary for Medicare between fraud and the actual administrative costs is arguably double to 3 times that of private insurers. If you leave fraud out, it's about 20% higher.
Thank you all for being on the panel today.
Chair thanks gentlemen and recognizes the gentleman, Mr. Pallone, for 5 minutes for questions.
Thank you, Mr. Chairman. I'm going to try to divide my time between asking Dr. Guterman about the Affordable Care Act and asking Mr. Davis about IPAB. So just bear that in mind if I cut you off. You heard me in the beginning that I'm against IPAD. I think that it's an usurpation of, congressional authority, and, I've never been in favor. I spent a lot of time trying to make sure it wasn't in the House bill, which it wasn't. But a lot of my concern is that it's very much like the BRAC, which I think is a disaster. And the concern about the BRAC is that it's totally stacked against Congress. I mean, I don't like the idea to begin with because it takes away congressional authority and gives it to the executive or an independent commission. But I also think it's stacked. There's no way we're ever going to overturn a BRAC decision. We've had 3 BRACs since I've been here. Every time we try to overturn it, we fail. And it's just, that's it. There's no congressional input. What I wanted to ask Mr. Davis quickly is, to what extent is IPAD the same? In other words, we've been operating with MedPAC. They make recommendations. We usually adopt them. I think we've been very effective. I don't see any need to change MedPAC. With BRAC, it's a one deal. You either vote it up or down. You need a supermajority, which we never get. Is the process similar and stacked in a way that it's going to be virtually impossible, as it is with the BRAC, to overturn?
Thank you, Mr. Pallone.
And I'm asking him as opposed to the D or R witnesses because I'm trying to be, not that you're biased, but I'm trying to get an unbiased opinion. Go ahead.
Yes, Mr. Pallone. As you said in your opening comments, there are very many similarities between the IPAB model and the Base Closure Commission. Principally is, as you indicated, that this is a commission that makes recommendations that go into force unless Congress stops them. That's also, of course, the case with IPAB. And whether under this procedure there are certain supermajorities that are required to overturn IPAB, and some of them, frankly, are de facto supermajorities as they are with BRAC. The idea that if Congress were to put forward something different, it would be vetoed and require a 2/3 override in both chambers. So in that way, it is similar to the base closure process. There are 2 differences I would highlight, though. The first is that Congress, unlike under BRAC, can change the procedures, or rather change the recommendations of IPAB as long as they fit within the same fiscal targets. That, as you know, is not the case with BRAC, where it's simply a up or down vote. Others have pointed out another difference, frankly, with BRAC, in simply that it's related only to facilities, while, of course, very important, can be thought of as very different to a sweeping policy area such as Medicare or health care reform. So I think in some there's similarities and differences.
All right, thank you. I appreciate that. Now let me ask Dr. Gutterman. I don't know if I was going to ask Judy Fetter to jump in too, but I don't know if we have time. I believe very strongly. The reason I didn't, I'm opposed to IPAD, but one of the reasons I also was opposed to it was because I thought that in the Affordable Care Act that we did a very good job about keeping costs down, and that we put together under Medicare and under the Affordable Care Act a sustainable trajectory, if you will, for the next generation with all the things that we did. And we don't need IPAB. Not necessary. So what I wanted to ask you is if you could outline how the Affordable Care Act's approach to reducing health costs is effective. You know, don't get into IPAD. I mean, to what extent do we set up a sustainable Medicare program here and get towards the costs without IPAD, with the other things? In 1 minute or so.
Okay. The Affordable Care Act laid out a number of tools that one could use to build a better healthcare system, and that's really the answer. It's not a matter of how much we pay so much as how we pay and what we pay for in healthcare and how healthcare is organized and delivered that needs to be addressed. And the Affordable Care Act, through the Innovation Center, through the Medicare Medicaid Coordination Office, those are two big steps, because that the Innovation Center is supposed to develop in collaboration with outside parties in innovations that help improve the delivery of care and save money in Medicare and Medicaid and across the healthcare sector. And they've already begun to initiate projects that involve states in broader initiatives. They're working with private payers. The ACO model that they're working on is one that's been picked up by the private sector. And in fact, there are a number of private sector initiatives that are ongoing to try to achieve the accountable care organization model that's been put forward in the ACA. And also having Medicare and Medicaid work together for a change. There are 9 million beneficiaries who are eligible for both programs, and right now the two programs just aren't well aligned to serve those beneficiaries' needs or to make sure that the money that's spent is well spent for those beneficiaries.
Thank you. Thank you, Mr. Chairman.
Thanks, gentlemen, and recognize the gentleman from Georgia, Dr. Gangry, for 5 minutes for questions.
Mr. Chairman, thank you very much, and I thank the panel. I'm sorry I had to step out to give a little quick speech, and I missed all of your testimony, but I certainly intend to read it all because what I heard was extremely interesting, a little bit diverse, which is to be expected. Before I go into questions, I want to raise one very important point today. In the press, Secretary Sebelius has often chided opponents of IPAB for suggesting that it has the power excuse me, to restrict access to physician services or life-saving drugs and treatments, otherwise known as rationing. And yet, under oath, here today, she has admitted that IPAB is charged with reducing excessive growth areas of Medicare spending, when President Obama's own OMB director states that excessive growth in Medicare spending is due to the availability and adoption of new, high-cost drugs and treatments. Finally, nowhere in Obamacare are the words rationing or excessive growth areas defined in statute, which means it is up to the Secretary and the IPAB board ultimately decide what is rationing and what cutting excessive growth areas means. It's up to them. And if the American public disagrees with how the Secretary or IPAB define rationing, they are, as I got from her testimony, prohibited from suing in court to stop it. So my concern here is simple. What one person considers rationing, another might refer to as reducing excessive growth areas of Medicare, known here as new treatments or drugs. And I believe the Secretary of Health and Human Services owes this committee and owes the American people a lot more clarity on this issue. Now, let me, in the remaining time, get to my questions, and I'll go to Dr. Well, let's see. I guess this would be Dr. Gottlieb, yes, and Mr. Roy. I am interested in your thoughts on the lack of clarity in the law with regards to one, rationing and reductions in excessive growth areas, along with the lack of judicial review, as I mentioned, for patients who feel the board is in fact denying them the benefits that they need to survive.
Well, I think the issue of rationing versus squeezing payments is a distinction without a difference, because we've seen already that when you squeeze payments, it effectively closes off access to care. And if there's some debate around what's happening in the Medicare program, and I would submit there's been some recent studies, one out of Massachusetts, that shows that Medicare beneficiaries are having a hard time getting access to providers up there. There's certainly no debate around Medicaid and whether or not patients under the Medicaid program have a difficult time getting access to medical care because of how low rates have been squeezed in that program. So long as IPAB is going to squeeze down payments, it's going to ration care. And I think the distinction is just semantics. What was the second question, Congressman?
Well, let me do this, Dr. Gottlieb. Thank you, and I'd like to get Mr. Roy's opinion on that same thing, if he can.
I think that I would echo Dr. Gottlieb's comments. I think that the importance of access to a physician cannot be understated. It's the most important thing. If you have a problem and you can't see a doctor for that problem, and that problem festers, you could have a much more serious medical condition. Children die of toothaches on Medicaid because they can't see a dentist and have their abscesses removed. There are serious, serious medical problems and problems of health care that if you can't have access to a physician, you can't do anything. So the fact that the IPAB is explicitly restricted from changing the mix of benefits really doesn't matter if somebody can't actually see a doctor in the first place.
Right. Well, I thank you both for that answer and that question. Now, I've got one more, Mr. Chairman. Secretary Sebelius, in her statements today, said that the administration has begun outreach efforts to fill these 15 seats on the Independent Payment Advisory Board. I'd just be curious to know, among this distinguished panel, whether or not any of you have been contacted, and I'll very specifically ask Ms. Cohen, has anyone from the administration contacted you about serving on IPAB?
No, probably because I'm suing them.
Ms. Fetter, Judy Fetter, has anyone from the administration contacted you about this?
Well, I've actually had lots of discussions about various aspects of the Affordable Care Act with the administration, and indicated that I would be proud to serve on the Independent Payment Advisory Board.
So the answer is yes.
Not
that sounds like a yes to me.
Asked would be grossly overstated.
Yeah. I take that as a yes. Mr. Roy, how about yourself? Have you been asked?
I'm afraid not, and I like my current job, so I'm okay.
Dr. Gottlieb?
I have been asked by some Senate staff, and I indicated that I'd be interested in being nominated, but I wouldn't want to serve. My only reason for being nominated is I want to write an op-ed outlining why the president shouldn't pick me to serve on the board.
So the response, Mr. Chairman, is that two of our panelists have been at least approached, and one is enthusiastic about the possibility of serving, and the other one is not. I thank you all very much for your response, and I yield back my time.
If I might,
Dr. Gutterman.
Mr. Chairman, would you yield me another 15 seconds? Did I not ask Dr. Gutterman?
No, you didn't.
I apologize, Dr. Gutterman. Have you been approached?
You don't need 15 seconds. No, I have not.
You have not. Okay.
All right.
Thank you. I yield.
Thanks, gentlemen. Recognize the gentlelady from California, Ms. Capps, for 5 minutes for questions.
Thank you, Mr. Chairman, and Dr. Fetter. Well, welcome to all of you, and thank you. It's a big panel, and thank you, each of you, for your testimony. I am in and out today, but it's my computer and my television set are all locked in so I could watch and listen. Dr. Fetter, the Republican plan for Medicare is to end it in 2022 and replace it with a limited voucher, whatever it needs to be called, with which to purchase a coverage on their own. Each senior then would have this opportunity or responsibility. It would solve the federal government's health care cost problems by asking seniors and those with disability to make sure that all the costs were covered, and using their voucher or subsidy or premium support to help them do this. The Congressional Budget Office estimates that the Republican budget would double annual costs despite this cost saving or cost shifting in the Ryan budget plan, the Republican budget would actually double the annual cost for Medicare by 2022 and nearly triple them by 2030. But this isn't just a problem for the future. Costs that large cannot be covered by our future seniors overnight. The Center for Economic and Policy Research looked into what these changes would mean for the retirement planning of people who are 54 or under today, which will be the first cohort of people who will live under, should the Ryan plan become actualized. They found that this plan would require that each senior would have to save about $182,000 for retirement over whatever they would be currently planning to save. Does this lead you to question the claim that the Republican budget doesn't hurt people today, only in the future?
It does indeed, Ms. Capps, and I appreciate your drawing attention to the fact that it's not just about the future, it's about the current period. And I would add to the concern that you have raised about people becoming uncertain as to what they would have to pay for insurance, and at the time when they're struggling to put aside pensions for the future, as well as take care of their kids, get them started and educated, that they would have to be putting money away to deal with future insurance costs seems to me an outrage. In addition to that, those who are talking about the repeal of the IPAB are also talking about the repeal of the Affordable Care Act. And so the protections that have been added for prescription drug costs, for preventive benefits, and other advantages that are available to current seniors, current beneficiaries, would also disappear. In addition, there would be an enormous, as this proposal has set up, there would be a huge cliff that occurs at that year when that goes into effect. And that seems an enormous burden to put on people into the future.
I would like to shift to the topic of Medicaid in just a minute, but I want you to respond briefly to many concerns that current seniors, today's Medicare recipients, are the ones who are voicing their concerns about this change in plan, even though they have been reassured that nothing will happen to them. There is a concern, and I haven't been able to address it. I wondered if you could, about what's to stop the majority from pushing forward this time. I mean, if it's going to be that kind of cost shift to start in, who are for those 54 now, what is there sacred about this contract that the current seniors now have with their government?
Since the people who would be affected in 2022 are paying in to Medicare for Medicare benefits as we speak, and they are expecting benefits, if the Congress is to changes that contract, there's nothing to say that they couldn't change the contract for those currently on Medicare.
Now, similarly, the Republican plan for Medicaid would also slash payments to states starting in just 2 years. It would be sort of a block grant approach to Medicaid. The match that is now guaranteed, the federal portion of it, would no longer be in the same way. I'm from California, and boy, there's tremendous concern about this because our state has terrific economic challenges with lots of people receiving Medicaid benefits, and to have this double whammy to the state of having to pick up more of the piece, which is apparently what is intended. Maybe you will explain what the cuts to Medicaid would have any effect on Medicare beneficiaries, some of them being dually eligible.
The Republican budget calls for a cut in federal funding to the states for Medicaid of about $750 billion. It is a huge cut in the resources going to states to support a population which, as we all know and are discussing with respect to Medicare, is aging and becoming increasingly in need of care. About a third of Medicaid spending is for long-term care services, long-term services and support, some in nursing homes, some outside nursing homes. The elderly, along with younger people with disabilities, but the elderly are primary beneficiaries. They are also beneficiaries of Medicare. We have improved services in recent years to try to get people who need long-term care services at home and in the community where they want to stay and not go into nursing homes. Those, as well as a host of other services for dual eligibles, Medicare beneficiaries who are also dependent on Medicaid, would be tremendously at risk, as we know from what states are already considering as cuts in benefits.
Thank you, Dr. Fetter.
Chair, thanks. Gentlelady, recognize the gentleman from Kentucky. Mr. Guthrie, 5 minutes.
Thank you, Mr. Chairman. Thank you for coming. I talked with the Secretary earlier today, and here's my concern. And people have paid into Medicare. And it's not $1 in, you get $1 out. I understand that. But we have a study from the Urban Institute says people average about 100,000 or a little more into Medicare and take out about 300,000. And people might say that's not a correct study or not. I don't know. And I've seen other studies about 3 to 1, what you pay and what you receive. And I'm 1964 into the baby boom. The beginning of the baby boom is 1946. We're all retiring. Starts now. Starts now. We know in 2024, I think the president even said Medicare is unsustainable. Now, they say during the Obama health care plan, President Obama's health care plan, they preserve Medicare, but he even said yesterday that it's unsustainable, the path that it's on. And what we're trying to do is offer a solution, a reform that preserves it for those who have it, and have it for people that are, I'm 47, I'm affected by it, to move forward, and to say that we paid into Medicare is not going to be there, that's just incorrect. That's absolutely incorrect, because it is a government-sponsored program that we're offering that uses Medicare dollars to move forward. So my question is, and Dr. Federer, with the vast of baby boomers moving, taking out $3 for every $1 we put in, how do you keep the system as it is for people in the future? You can't just, they talked about DME, medical equipment. If you stopped people from buying the scooters on the free advertising, I'll get you a scooter on television, you can't save enough money to make up for the demographic move, the wave that's coming of baby boomers, and it starts today. It has started today.
Mr. Guthrie, I am an earlier baby boomer. I will be 65 next year, so I'm part of the pressure here, and there's no question that it's growth in population that is what's driving Medicare spending, total spending, much more than any period in the history of the program, as the enrollment grows, because the per capita spending growth, remember, for Medicare is much slower than private sector growth. But what's now come to drive along with that spending growth, cost per beneficiary, is the number of beneficiaries. Right. And it is true for all of us that we don't want 1965 health care when we're in 1985 or in 2020. We want the health care that is available.
Right, so how do you have the fee-for-service system as it exists today with the vast baby boomers retiring and not talking about cost shifting? I have a 17-year-old daughter who in 30 years will be 47 years old, which is my age. And in 40 years, according to CBO, 100%, if you have 18% of revenue GDP coming to the federal government, will be for Medicare, Medicaid, and Social Security. So the greatest generation who provided the interstate highways, fought World War II, did everything to give my generation the opportunities. My generation, if we don't address it, I know everybody's here criticizing everything we're doing, but if we do not address it, my child will go to work when she's my age for me to be retired. Well, solely for me to be retired.
I understand your concern, and I share it. I have 4-year-old twin granddaughters, and I'm doing my best to guarantee affordable health care for them well into the future when they're my age and older. And what we're all concerned about here is how to do that. And the way to do that is to change the overall health care system. The Affordable Care Act gave Medicare the lead in changing the way we pay for health care and making the whole system more efficient. And that's what we need to do, because an alternative is simply to deny care to those who don't have the resources to pay a cost that is going up. So
we've got to deny care, and just like Medicare Part D, it's 40% underestimate, because health plans have to compete. Anybody can answer. I'm just not asking one question.
Let me, if I may stay with you, I don't think Medicare Part D offers you the answer there, sir, and the cost of prescription drugs are rising as well. We need to make the system more efficient.
I'm about out of time.
Yeah.
I'm sorry to cut you up. I only got 40 seconds.
No, I think that one of the things that we see with the CBO projections is the CBO consistently underestimates the importance of cost shifting in medical expenditures. So Medicare Part D has a significant cost sharing component, which is the donut hole, the so-called donut hole, which is now going away. But that donut hole is a big part of the reason, along with the choice in plans, that Medicare Part D has come in 40% under budget. Whereas with the conventional, traditional parts of the program, expenditures have skyrocketed out of control because there's been minimal cost sharing.
And the administration wants people making $250,000 or more to pay more taxes. but they don't want them to pay more for their health care. And what our plan does, if you're at the lower end, you still get covered, and as you have the higher end, you'd pay more. And so instead of a $250,000 a year person at 65 years old paying more for their health care, they're going to send the bill to my 17-year-old daughter and my 16-year-old son and my 13-year-old daughter.
I would make a point about that, which is that because medical expenditures grow at faster than the rate of GDP, you can never raise taxes fast enough to compensate for the rise in healthcare spending. So it's always much more efficient if you want to means test on the spending side rather than on the taxation side.
Chair, thanks the gentleman.
If I can.
And recognize the gentleman from Texas, Mr. Gonzalez, for 5 minutes.
Thank you very much, Mr. Chairman, and I really appreciate the testimony of all the witnesses. I may not agree with a few of you, but I do think that IPAB is actually one of the best approaches as trying to get a handle on what are exploding healthcare costs. And I think we all acknowledge that healthcare costs consumes too much of our GDP, that employers are no longer providing it to the degree that they used to provide it to their employees, that individuals in this country very likely cannot afford health care. It's that simple. That 50 cents out of every dollar spent on health care comes from some entity of government. And we're saying, and I share some of the real concerns of my colleagues on the other side of the aisle about where we're going to be and such. A generation that may have provided great opportunity for us, the interstate highway system, but I'll remind everybody that what Eisenhower and others did in the 50s to give us that interstate highway system was to, in essence, raise the gasoline tax, what would be the equivalent of 96 cents a gallon today. There's not one of my colleagues, and I hate to say it, I don't think I would vote on that myself today. So there's a difference that's going on out there as to what people are willing to pay for in this country and still expect to receive the benefit. I am concerned about something you said, Mr. Roy, and because in the United States, either the government is subsidizing the payment for health care or the private sector is. But the individual consumer, and there is no other product or service that has that kind of status in this country that I'm aware of. But I am somewhat disturbed by the fact that it must be all of the patient's fault. And I'm concerned about some aspects of IPAB. I share the concerns of my physicians in my district that are saying, where will our input? How are we guaranteed that we have something to say as far as the information that's going to be considered by the members of this board? I am really worried about that. But where does the responsibility lie? I will tell you right now, if I go into my doctors, and I've been going to them for a number of years, and if they tell me I need a certain procedure or a certain test, I really don't question it. Now, let's just say I didn't have Blue Cross Blue Shield because it's employer-sponsored. I'm a member of Congress. But I was going to pay that out of my own pocket. I'm still not real sure. Your premise is that I'm going to shop around, or I'm going to go around and say, I'm not sure that I really need that test. I think I'll go and see another doctor and get another opinion, which is going to cost me money and such. So where's the responsibility lie? Do you believe that maybe the physicians have a responsibility only to provide that service, which is absolutely necessary? I'm not going to get into the argument of unnecessary testing and everything else, because I've got the gold standard in the state of Texas, and it has not brought down the cost of health care in the state of Texas. It has brought down the cost of insurance policies for certain specialties. So where is this shared responsibility? How do we get a handle on this? And isn't IPAB maybe a method of achieving that goal?
If one looks at a number of studies around the behavior of patients and physicians with high deductible health plans and health savings accounts, where there is more consumerism, where there is more ability to shop for procedures and tests and office visits, you see a lot more intelligent consumption. I think in Washington we have an excessively pessimistic view of the ability of individuals to make intelligent decisions about their own care. Especially in the days of the internet, people do a lot of research, people have a lot of knowledge. If we had a system where consistently, across the system, for everyone, there were more and more people who could shop for care, who bought insurance for themselves instead of having it provided by someone else, you have more of the ability to start thinking in the way that people need to think about, well, do I really need that test? And if the doctor says, yes, I really do think you need that test, even though it costs $2,000, the patient might say yes. But maybe the doctor will say, you know what, that test is $2,000. I think it might benefit you a little, but maybe it's not worth paying for you right now because it's $2,000 and you are very unlikely to benefit from it.
Don't you
Those
think the
discussions don't
determining
happen.
factor, though, really, in most tests, and I know this is going to be controversial, is whether it's covered or not?
Could you repeat the question?
What I'm saying is whether you have access to a number of tests or not is whether that test is going to be paid for through some subsidy, either through private insurance or government. Isn't that the truth?
Not necessarily, because again, if you have co-pays, deductibles, health savings accounts, and other mechanisms by where the patient shares in the expenditure, the patient has more of an incentive to monitor those expenditures and make sure they're being executed intelligently.
And Mr. Chairman, I'm going to ask your indulgence just to give Dr. Gutterman a couple of minutes to respond to some of the comments.
Dr. Gutterman?
I promise this will be brief. I wanted to point out that in my written testimony, I point out that 58% of total Medicare spending is accounted for by 10% of Medicare beneficiaries who account for an average of $48,000 in Medicare costs. These are people who are very sick. It's not that they're incurring those costs because they're bad shoppers. The other thing I'd point out is that there was a large-scale experiment on the impact of out-of-pocket costs on the utilization of health care, and what it found was that, indeed, higher out-of-pocket costs reduce the utilization of health care, both desirable health care and undesirable health care. So putting the onus on the back of Medicare beneficiaries, especially ones who are sick, who are the ones who are spending the money, is kind of a difficult way to make sure that the system runs efficiently.
Chair thanks the gentleman. That completes this round of questioning. We'll have one follow-up for each side. Dr. Burgess.
Thank you, Mr. Chairman. Dr. Goodman, I recognize one size fits all doesn't work, and that's one of the reasons I've got some concerns about what we've done, what Congress has done with the Affordable Care Act. But I'm a big believer in letting people spend their own money for health care, but I also recognize that there are populations out there where this would not be the wisest course of action. Now, when I practiced medicine, I kind of considered myself to be, well, what I've learned now, we call it a medical home, but I mean, I was always the one that arranged things for my patient. I always went the extra mile to do things that were not necessarily reimbursed, but were required as part of giving good care. And I don't remember if you were there at the Commonwealth meeting in January, but it came up during the course of that meeting that one of the members of Congress who was there said, healthcare is so complicated, I have to use a concierge doctor to sort of sort things out for me. And this was not a Republican member who said it. So it was kind of a shock to hear this come from a member of Congress. And I asked Don Berwick. Dr. Berwick was there. He was on that panel. I said, so Don, you just complained about 20% of your patients consuming 80% of your resources. Why don't you buy these folks a concierge doctor? Or why don't you directly contract with a physician to be responsible for a pool or panel of patients in the dual eligible world? I mean, we all know who those patients are. They're readily identifiable. They don't move around a lot. They stay in one place. So wouldn't that be a population that would be amenable to a different type of practice model? You talk about wanting to change the payment structure for everyone, and maybe that's not necessary. Maybe we could look at this defined population and say, we want to do a better job for these patients. And we know they are not served by having to go from doctor to doctor to doctor to doctor. Why don't we put one person in charge? We used to have a saying when I was in practice, too many doctors means no doctor. And that's exactly true. So if you had one person who was directly accountable to that arguably very complicated and very ill and multiple medical conditions patient, if you had one doctor, don't you think you'd get a better return on investment for that money that you spent? Yes, Stewart, yeah.
Dr. Burgess, I agree with everything you said, and I think that's the underlying philosophy of the medical home model. I think it's the underlying philosophy of the Accountable Care Organization. And I think, you know, what this represents is that I think we all agree that the healthcare system needs to work better to provide care, especially for those with multiple chronic illnesses and the people who are sickest. And I think whatever approach you take, whether it's a
but sir, that's not new information. You said you've been working on this for 30 years. Where's the beef?
The medical home model's been one that's been talked about and tried in limited, in limited scale. But
and yet, I'm the kind of doctor who was providing that type of care, and he basically ran me out of business.
Right.
By not paying the freight, by not paying for these activities.
The problem is that in our current fee-for-service system, people get punished for doing the kind of care that you'd like to provide. And we hear, people from various systems around the country saying, that can enumerate the way they get punished for doing good things for their patients. But under the current payment system, those good things are rewarded with lower payment, and so in a sense they're punished for doing what they'd like to do for their patients. So I think we can agree, and maybe this is a platform for kind of cooperation across the aisle, that we agree, I think, on the kind of care we'd like to see, and we agree that getting to that kind of care is what we really need to solve the problems that we're all concerned with.
And I would just submit the obstacle so far has been CMS. Not they haven't been a facilitator; they've been an obstacle. But I welcome the opportunity to work with you on this. Obviously, I've got some discussions going on with other people, and I would welcome the Commonwealth Fund being part of that discussion as well. Thank you, Mr. Chairman. I'll yield back.
Sure. Thanks, gentlemen. Mr. Pallone for a follow-up.
Thank you, Mr. Chairman. I'm going to ask Dr. Gutterman. Before I was asking you questions about how the Affordable Care Act would save money even without IPAB. And I believe very strongly that it saves money, particularly for not only the government but also for beneficiaries, as opposed to the Republican budget, which I think is going to cost Medicare beneficiaries a lot more. So I'm just going to ask you to compare and contrast the Affordable Care Act's approach to saving money and that of the Republican budget, particularly as beneficiaries are affected, if you would.
Let me start by adding something I omitted in my answer to your previous question, and that is the Patient-Centered Outcomes Research Institute, which is charged, a public-private organization that's charged with producing evidence to help make better clinical decisions in the healthcare sector, which I think can only help. It's not like those decisions aren't being made every day millions of times. It's just they're being made with too little information. But I guess rather than contrast the two approaches, I'd say that under both approaches, the problem's not solved unless we change the way healthcare is delivered and paid for. Because in the end, you need to control the cost of healthcare, and you need to control the way healthcare is delivered and the way it's targeted at the people who need it most, and providing the services that benefit people most. If you provide people with premium support, if the cost of healthcare isn't controlled, they're going to find themselves more and more left out of the market for health insurance. If you just rely on cutting payments alone, you're going to make access more difficult for Medicare beneficiaries. If you address more broader issues, either through the IPAB or other mechanisms that are already in place with the Affordable Care Act, then I think you can achieve what you want to achieve, and then even perhaps make the Independent Payment Advisory Board unnecessary because you've controlled costs already and met their targets.
Thank you.
Dr. Cassidy, you came in, missed the first round. You have questions?
Yes.
Recognized for 5 minutes.
I apologize for having to leave. Dr. Gutterman, I kind of had a schizophrenic approach to your testimony. Part of it I liked, and part of it I'm thinking, what's the guy thinking? So the part that I liked is where you mentioned that we have to take a global view. History clearly shows that Medicaid and Medicare will do a downward pressure upon their cost and shift that to the private sector. I mean, there's no mystery about that. I could almost stipulate that. There's a good article by one of maybe McKinsey, maybe somebody else, about the hydraulic effect. The more Medicare, the more social, the more Medicaid you have in your book of business, the greater the upward impact upon upon cost for small businesses in the private health insurance market. So what gives you kind of encouragement that IPAB, which is really just looking after the Medicare book of business, will not succumb to that same temptation that Medicare always has, and Medicaid specifically really has, to shift costs to the private sector?
Okay. Let me first, the term cost shifting is often misunderstood, partly because it assumes that the cost of health care is somehow immutable and can't be reduced by better examination of what is appropriate to provide.
I will give you that we can do a better job with what we have, but if Medicaid pays 60% of cost, then clearly there has to be a makeup someplace.
Well, but that depends on whether you think costs are right. But beyond that, what I think is important to realize, to think of IPAB in the context of, is the broader set of tools that are available to us. That I think there's more really unprecedented push to use to address the problems that we're facing now. And I think, looking at IPAB alone is not going to solve the problem. But IPAB is in the context of a broad array of policies that are on the table that may, in fact, be able to solve the problem. And it's also part of a process that I think the Congress has to be involved in. Sometimes
let me pause you there. Let me pause you there because I have limited time. Mr. Roy, what would you? I think we know where Dr. Gutterman is going. What would be your thoughts?
Yeah, so I think you actually, Dr. Cassidy, bring up the most important point around this faulty idea that somehow Medicare expenditures are growing more slowly than private sector. Because what happens is the Medicare shifts costs to private insurers. So if I have two Chevys that I paid $10,000 each for, and the government comes to me and says, I'm buying that one Chevy from you for $5,000, and I lose $5,000 on that, maybe I charge the other guy $15,000 to make it up, and that's effectively what cost sharing is. It's more complicated than that in reality, but that's basically what Medicare does. Medicare cheats by underpaying for care and restricting access, and these are the problems that, unfortunately, have a significant, are what IPAB is all about.
Dr. Gottlieb, what are your thoughts, please?
Well, I think IPAB has no alternative but to try to squeeze payments in the short term because anything it could do to try to fundamentally reform payment systems the way care is delivered isn't going to score well. CBO, they're going to have to achieve immediate savings. I think one of the larger problems here is that a lot of the reforms in the Accountable Care Act and a lot of things we're talking about here today are predicated on changing the delivery model, getting better coordination of care. Those require investments in innovation in how care is delivered. And the only way that providers, hospitals, doctors are going to invest money to better coordinate care is if they can earn an above market rate of return for a sustainable period of time on their invested capital. And the problem is that the administration's legislation and regulations don't allow for that. And that's why you're seeing the adverse reaction to the regulations on the accountable care organizations. I could tell you I've seen a lot of business plans floated with venture capitalists on creating new accountable care organizations or services that would provide services to the accountable care organizations. I haven't seen a single one get funded for that precise reason, that the presumption out there is you're not going to be able to earn a return on capital. If you do earn an above market rate of return on capital for any length of time, it's going to be regulated. If you continue to earn above market rate of return, it's going to be taxed. And if you continue to earn it after it's taxed, you're going to be criminalized.
But on the other hand, if you don't, you'll be subsidized.
And when it's gone, you subsidize it.
Now, and that is without saying that, again, as I mentioned earlier, the New England Journal of Medicine article that reflected upon the 10 accountable care organization pilot studies, places specifically chosen so that they would be more likely to succeed, did not. Now, Dr. Gutterman, you must have some thoughts about that.
In fact, I was at CMS when we started up those demonstrations, and in fact, I would describe that demonstration as a rousing success for several reasons. One is that half of those 10 sites were able to achieve measurable savings according to the rules of the demonstration and receive bonus payments for saving Medicare millions of dollars compared to the targets that they were working under.
Now, in fairness,
secondly,
in fairness, it was a 3-year demonstration project, and I think 3 did. And it was not every year, so and several did not.
In the last 3 years, there were 5 of them, and all of the sites achieved noticeable increases in the quality of care, which perhaps was even more important, certainly without spending more money. And there was some, as there will be, and I think something that the IPAB or any other mechanism is going to have to deal with is compared to what. and how you deal with getting either CBO scoring or the Office of the Actuaries and CMS to agree that a particular project is going to save money. But that's going to have to be dealt with. That's a methodological issue that I think needs to be dealt with.
I'm out of time. I yield back. Thank you all.
Chair, thanks to the gentleman.
Mr. Chairman?
Go ahead.
Did you rule on my unanimous consent request for Senator Cornyn's letters from Scott and White?
Okay.
Dr.
There's
Rohack?
no objection. Without objection, so ordered.
Thank you.
Thank you, and thank you to the panel. Very informative. Appreciate you your patience. We'll now change panels to a fourth panel, and I'll introduce the fourth panel as they come to the table. Joining us on our fourth panel are Dr. Alex Velodka, a neurosurgeon. He is the Chief Executive Officer at the Seton Brain and Spine Institute, Austin, Texas. He represents the Alliance for Specialty Medicine. Secondly, we have Mary Greeley, who is president of the Healthcare Leadership Council in Washington, D.C. Then we have Dr. Jack Lewin, Chief Executive Officer of the American College of Cardiology. And fourthly, we have Teresa Morrow, who is the co-founder and president of Women Against Prostate Cancer. Your written testimony will be entered into the record. We ask that you'd summarize your opening statements in 5 minutes each. Dr. Velodka, you may begin your opening statement.
Great. Thank you, Chairman Pitts, Ranking Member Pallone, members of the subcommittee, for allowing me to testify about the Independent Payment Advisory Board. My name is Alex Velodka. I'm a practicing neurosurgeon from Austin, Texas. And as far as I can tell, I'm the only practicing physician who has the privilege of testifying before you here today. I'm pleased to be here today on behalf of the Alliance of Specialty Medicine, which was founded in 2001 with the mission to develop sound federal health care policy that fosters patient access to the highest quality specialty care and improves timely access to high-quality medical care for all Americans. As advocates for patients and physicians, the Alliance and its members welcome the opportunity to contribute to the ongoing debate regarding IPAB, or as we think about it, the Impacts Patients Adversely Board. We're deeply concerned about the unintended consequences that will result from the establishment of IPAB. We oppose its creation, and we are now urging Congress to immediately act to repeal IPAB. Now, I realize that by this time in our IPAB-a-thon here today, you've had an earful, and I don't want to be overly repetitive, but I do want to make you aware that America's specialty physicians have numerous concerns with both the concept of IPAB and its structure. First and foremost, the Alliance believes that under the IPAB, access to specialty care will be severely limited due in part to the additional payment cuts that it will impose on physicians. Medicare physician payments are already well below market rates, as we heard earlier today, and they continue to be subject to deep cuts as a result of the flawed SGR formula. Cuts to physician reimbursement under IPAB will only exacerbate those already imposed on physicians as a result of SGR cuts and other cuts that are going to occur each year as part of the Medicare physician fee schedule for things like problems with electronic health record, value-based quality modifiers, meaningful use requirements, and things of that type. Our physician survey data demonstrates that these cuts, including those imposed by IPAB, may ultimately force specialists out of the Medicare program, severely threatening Medicare access to its beneficiaries to innovative therapies and quality of care. And to echo something that was said earlier today, participation in Medicare is not on or off. Many physicians still continue to participate, but they have to limit the number of Medicare patients they can see in their offices or otherwise provide access to. Our second concern is that IPAB lacks accountability, sets a dangerous precedent for overriding the normal legislative process. As drafted, the IPAB has little, if any, accountability to the Medicare beneficiaries whose health care will be affected by its decisions. And yet its recommendations will have the force of law if Congress fails or chooses not to act. The Alliance maintains that Congress should be the entity to legislate health care policy, not an independent board. An additional concern is that the limited transparency of IPAB proceedings severely limits congressional oversight of the Medicare program and replaces the transparency of hearings like this one with a less transparent process overseen by the executive branch, not the legislative branch. The IPAB statute also provides fast-track procedures for IPAB proposals, which will automatically become law unless Congress can act very quickly to amend the proposal. Congress already faces significant challenges in moving legislation through the regular legislative process, and we seriously doubt its ability to jump through all the procedural hoops within the required 7 months to override IPAB recommendations. Although its proponents argue that the IPAB is critical to holding down the growth in healthcare spending, providers representing nearly 40% of Medicare expenditures, including hospitals and nursing homes, are exempt from the reach of IPAB for several years. We agree with the CBO that this will place greater pressures to achieve savings on physicians, which, as I previously noted, will ultimately curtail seniors' timely access to specialty care. Finally, and again as discussed earlier today, the process for making appointments to the IPAB is imbalanced because appointments are made solely by the President. This structure also ensures that the board will have inadequate expertise, since it fails to include practicing clinicians like me, who can draw from firsthand experience when considering how proposed recommendations could impact the delivery of health care from both a patient and provider perspective. Although the Alliance recognizes the need to hold down the growth of Medicare costs, the IPAB is simply the wrong way to go. But the more than 100,000 physicians represented by the Alliance reiterate our pledge to work with Congress to identify more appropriate ways to achieve this goal. I ask that you make the same commitment and work with the medical community to meet the challenges facing our healthcare system and not leave these very important decisions to a group of 15 unelected and largely unaccountable individuals. Mr. Chairman, thank you again for allowing the Alliance to testify, and I'll be happy to answer any questions.
Chair thanks the gentleman. Recognize Ms. Greeley for 5 minutes for opening statement.
Chairman Pitts, Ranking Member Pallone, members of the subcommittee. On behalf of the members of the Healthcare Leadership Council, I want to thank you for the opportunity to testify on the ramifications of the Independent Payment Advisory Board, or IPAB, for patients and the U.S. healthcare system. Now, already today, you've heard a number of perspectives on IPAB. While I request to submit my full testimony for the record, I would like to briefly share the point of view of HLC members who are chief executives of the nation's leading healthcare companies and organizations. The views I express today reflect the conclusions of hospitals, academic health centers, insurers, pharmaceutical and medical device innovators, distributors, pharmacies, and other sectors within our healthcare system. Mr. Chairman, we fully agree that it is imperative to make Medicare a more cost-efficient program, that its current spending growth rates are unsustainable. The question is how to address this challenge in a way that strengthens and does not undermine the accessibility, the affordability, and quality of health care for Medicare beneficiaries and for all Americans. Now, there are different approaches available to Congress in pursuing this objective. On one hand, you have the direction embodied in IPAB to simply slash expenditures whenever spending exceeds a certain arbitrary level. Now, we can talk all we want about the expertise of those who conceivably would be serving on IPAB, but those credentials are largely irrelevant. IPAB isn't designed to develop meaningful long-term reforms to strengthen the value of the Medicare program. Rather, its mandate is to achieve immediate, scorable savings. Now, according to analysis from the Congressional Budget Office and the Kaiser Family Foundation, this imperative to make immediate reductions means that IPAB's course of action will likely focus on reducing payments to providers. The impact of this action is easy to predict. Today, as we've heard, an increasing number of physicians are restricting the number of Medicare patients that they see in their practice because of low payment rates. According to a survey of the American Medical Association's members, that number includes 1 of every 3 primary care physicians. Now, if IPAB, as expected, cuts payment rates to even lower levels, then we will almost certainly see more physicians unable to treat Medicare beneficiaries, and access will become a more critical issue. With those 80 million baby boomers entering the Medicare program at an average of 9,000 per day, and the projected physician shortages already on the horizon, we could find ourselves on the verge of a healthcare access perfect storm that will hit seniors the hardest. These payment cuts also will likely result in greater cost shifting to private payers and their beneficiaries. It should also be noted that IPAB will function much as that deadly robot in the Terminator movies. It will have a single-minded, relentless focus on achieving its cost-cutting function. There is no statutory latitude to take into consideration unforeseen public health concerns that may, in the short term, necessitate more, not less, healthcare spending. It does not take into consideration the potential of new medicines and devices that may have high upfront cost, but that will reduce Medicare spending in the long run. Now, there is no question that Congress has more flexibility than the IPAB in being responsive to healthcare circumstances, capabilities, and needs, and will certainly be more responsive to public concerns than an unelected board ever will be. There are far more preferable approaches to making Medicare more cost efficient. There are multiple provisions, for example, as we've heard today, within the Patient Protection and Affordable Care Act that are focused on moving away from the fee-for-service model and aligning incentives to reward providers for high-quality, cost-effective care. We should give these reforms an opportunity to work before we think of turning to an approach as extreme as the IPAB. Also, throughout the country, private sector healthcare providers are demonstrating innovative ways to generate better health outcomes with less cost. We've documented many of these successes in our HLC Value Compendium, which we provided to CMS, and I'd like to submit for the record. Mr. Chairman, thank you again for this opportunity to present our views. In summary, the members of the Healthcare Leadership Council believe that the IPAB mandate and inherent inflexibility will inevitably result in reduced healthcare access for seniors. We need instead to turn to payment and delivery reforms that will actually improve care while reducing costs. Thank you, and I'll be happy to answer any questions.
Chair thanks the gentlelady and recognizes Dr. Lewin for 5 minutes.
Thank you very much, Chairman Pitts, Ranking Member Pallone, and Vice Chair Dr. Burgess. Pleasure to be here today representing the American College of Cardiology, all of America's cardiologists, and the many cardiovascular nurses and researchers. Cardiovascular medicine represents 43% of Medicare costs today, still unfortunately the #1 killer in America. Yet we have made some real progress. In the last decade, morbidity and mortality for cardiovascular disease has gone down by 30% in the United States. And that's because of new imaging techniques, new procedures, new therapeutics, new approaches to prevention, but also because for the last decade we've been able to take electronic tools, guidelines, performance measures, appropriate use criteria, and apply them closer and closer to the point of care to measure best evidence and get the best results, reducing unnecessary spending and activity. The door-to-balloon campaign is one approach where we've been able to speed the treatment of heart attacks in hospitals through system improvement using the data we collect from the registries we have in 2,500 U.S. hospitals. We've reduced the variations from heart attack treatment by a factor of 3, the length of stay from 5 to 3 days, the cost by 30% across the United States just in the last 3 to 4 years. Unbelievable. But here's the thing. We got no reward for that, no incentives for that. It happened because we believe it. The IPAB, as proposed, is going to fail. Its price controls won't work. It's a mechanism that represents the past, not the future. And we're very concerned about that. In fact, we probably ought to get rid of the existing flawed price control mechanism, the SGR, which we have on the books right now. Hasn't worked very well, has it? We get rid of that one before we launch the next one, please. We need an immediate and different approach for a very different IPAB to bend the cost curve. In the last 40 years, amazingly enough, the healthcare costs have gone up, multiples of the GDP, 40 years in a row. This is really amazing. If we got the GDP, the healthcare costs were GDP plus 1%. The U.S. national deficit would go away at 20. So, you know, it's a patriotic kind of thing, calling for me at least, for the profession of medicine, physicians, hospitals, and others to get on this. We really have to bend the cost curve. And can we do it? Yes, we can. If we get the unnecessary spending out of the system, we can get this done. Now, I think that to do that, we've got to go back to using those tools at the point of care, the guidelines, the appropriate use criteria. These measure not only quality, but for appropriate use, effectiveness in terms of efficiency, spending, getting the right test the first time, getting the right procedure the first time, etc. We can now measure comparative outcomes. We couldn't do that 10 years ago. We didn't have the electronic means to do that. We couldn't tell doctors in hospitals how they're doing as to whether they're spending the money efficiently, providing patients with the best care. Now we can. So let's provide the incentives for consistent best evidence at the point of care. Let's systematically reduce variation, get rid of the unnecessary testing procedures, unnecessary admissions and costs. Let's use that kind of a price control approach. That is not the IPAB folks. If we want the IPAB to work, it's going to have to be so radically modified to do the following. It's got to develop incentives for doctors and hospitals to reward quality and not volume. Setting price controls on volume is not going to solve our problems. We already know that. It needs to apply to all healthcare sectors, not just the doctors. Wait a few years and add the hospitals later. It needs to be flexible to attract people who really understand the healthcare system or in it and see it from various perspectives, and it's currently designed so that it can't do that in terms of the 15 members it's going to attract to be full-time parties as designed now. So, you know, we're committed to the cause of the IPAB. We think its purpose is absolutely right on. We believe in that purpose. We see it as, in fact, a national kind of patriotism. Let's compete in a global economy and get healthcare costs down without destroying innovation in healthcare and without destroying patient care itself. So let's rethink the IPAB or amend it so that it can achieve the kinds of targets that will provide viable Medicare, the targets for Medicare spending that will keep the healthcare system viable, that will stifle, that won't stifle innovation and won't harm patient care. Thank you very much.
Chair, thanks, gentlemen. Recognize Ms. Morrow for 5 minutes.
Thank you. I'd like to thank Chairman Pitts and Ranking Member Pallone and the committee for for holding this important hearing today, and I appreciate the opportunity to submit my testimony on a topic that will definitely have a significant implications on the lives of thousands of men, women, and families. My name is Teresa Morrow, and I'm co-founder and president of Women Against Prostate Cancer. Our mission is to unite the voices and provide support for the millions of women affected by prostate cancer. As healthcare leaders of the household, the role that women play in all phases of prostate cancer, from preventative screenings to treatment and follow-up care, is critical. As you know, prostate cancer, as with any cancer, impacts the entire family. Our own co-founder, Betty Gallo, experienced the impact of this firsthand when her husband and your former colleague, Representative Dean Gallo, was diagnosed with prostate cancer in 1992 and subsequently died from the disease in 1994. Since his passing, many advancements in treatment and access to screenings and quality health care have saved the lives of thousands of men diagnosed with prostate cancer, and fewer families have to suffer the loss of their loved ones as the Gallo family did. We are here today because we are concerned about the effect that implementation of the Independent Payment Advisory Board will have on Medicare patients and families, including the large number of seniors that are diagnosed with prostate cancer each year. We share your concerns for more sustainable health care costs, but do not believe that IPAB is the best way to achieve this goal. We believe that IPAB will have a negative impact on patient access to quality care. IPAB's power to dramatically cut payments to healthcare providers and physicians who provide services to beneficiaries will likely result in fewer providers being willing to accept new Medicare patients and limiting seniors' access to quality providers. We are concerned that IPAB could ultimately limit access to certain treatments or medications. While IPAB may be specifically prohibited from rationing care, reduced payments for certain medical services and providers could lead to the unintended consequence that beneficiaries should have access to certain treatments and therapies, but not to others. As a prostate cancer organization, we are particularly concerned that patients may not have access to new and innovative therapies to treat cancer that can ultimately improve and save lives. Treatment decisions should be made between a healthcare provider and a patient and his or her family and not be limited by an unelected board. I recently spoke with a prostate cancer patient named Doug McGill from Northeast Ohio, and when he was diagnosed with prostate cancer, he began his quest to determine which treatment to pursue. He did all the things an informed patient would do. He got a second opinion, spoke with other patients, family, and friends, and he did a lot of research. Ultimately, he chose to travel across the country to Loma Linda University Medical Center to receive proton radiation therapy. He chose proton therapy because of his fear of the side effects, such as impotence and incontinence, that other treatments may cause. Doug expressed his concern to me that an entity like IPAB may have restricted his right to choose his treatment. By limiting his access to certain providers, he may have been forced to choose surgery instead of proton therapy and possibly left incontinent and impotent for the rest of his life. Like Doug, each prostate cancer patient is unique, and that should come into play when determining a treatment path. Patients and providers should have the right to choose what is best for them. Another negative impact to seniors will be IPAB's requirement to achieve savings in one-year periods. This means that the focus will largely be on cutting payments and other short-term savings rather than on long-term savings and reforms that could save money or help patients avoid unnecessary care in the future. More emphasis should be placed on prevention. Catching health problems in their early stages while they are still treatable and preventable is the best way to ensure that seniors stay healthy and incur less expense to Medicare in the long run. More emphasis should be placed on participation in benefits like the Welcome to Medicare physical. Currently, less than 10% of those eligible to participate in this screening do so, even though it can serve to provide guidance for seniors' health maintenance as they age. Finally, we're concerned about the lack of oversight of IPAB. The board has the power to change laws previously enacted by Congress without actually needing congressional approval. Furthermore, the Secretary's implementation of IPAB's recommendations is exempt from judicial and administrative review. We are also troubled that there is no patient representation on the board and that IPAB is not required to hold public meetings where the voices of patients, caregivers, and families can be heard. Important healthcare decisions that can dramatically impact patients will be made by an unelected board without accountability to the public. In conclusion, I would like to thank the committee and just reiterate that while we agree that healthcare costs do need to be reined in, we do not believe that IPAB is the right way to do so. Thank you.
Chair, thanks to the gentlelady. Thanks, panel, for your testimony. We'll now begin questioning, and I'll recognize myself for 5 minutes for that purpose. Dr. Volodka, you state that the IPAB, as it has been described in statute, will simply ratchet down cost in the absence of adequate clinical expertise or the research capacity to examine the national and regional effects of proposed recommendations to ensure patients are not unduly impacted. Are you concerned that the IPAB's mandate to cut spending in the short term will undermine longer-term improvements to Medicare and the health care system in general? Would you elaborate?
Yes, thank you for the question. One aspect of this which has not been addressed much this morning is the fact that Medicare not only funds a lot of practitioners in the private sector, but also is a huge contributor to medical schools and other places that do research. And that margin is getting thinner and thinner. As one who spent over 12 years as a medical school faculty member, I can attest to that firsthand. So if Medicare reimbursements to all the physicians participating in medical schools are going down, that leaves very little excess room for research to develop new treatments, as well as for education of medical students and residents who are going to be the next generation of practitioners. And those are the most fertile source for new innovations and ideas coming forward for the several decades following their training. And moving to people who are already in practice, there's a lot of very clever people practicing out there who come up with better ways to do a procedure or treat a patient or treat a disease. But again, if there's less excess capital flowing into their practices, they're not going to have the luxury of that time to develop new and better treatments.
Thank you. Ms. Greeley, many, if not most, healthcare analysts think that meaningful health reform will occur over a number of years. Are the short-term scorable proposals that the board is likely to have to make consistent with meaningful health reform, in your opinion?
Well, actually, I think it could be a barrier to that long-term meaningful reform. I think, as you've heard among this panel, that things that could save Medicare money in the long run may require a capital investment up front. We look at the current development of accountable care organizations. It requires investment. As Dr. Lewin has pointed out, we need to have health information technology as an important tool. Again, these are things that in the short term could increase spending, and this idea of having a year-by-year, one-year budget reduction requirement, I think really could impede some of those longer-term savings that would improve quality as well as reduce the cost of care.
Thank you, Dr. Lewin. In your testimony, you state that, quote, until the SGR is replaced, you cannot support implementation of the IPAB, end quote. Does this mean that if the SGR is replaced, you would then support the IPAB?
Thank you for the question, Mr. Chairman. No, I think the IPAB, I think the SGR needs to be replaced, and that's going to be exceedingly difficult, as you well know, because of the accumulated debt that it has accrued. I think that we need something different from the IPAB and the SGR, something that is not a price control approach. I think if we in fact, let's move beyond from away from the past and really innovate in health system reform to a new future where we start rewarding for better quality, more efficient care rather than the volume of care. And so, we need to get on this now. We may not get the SGR fixed for years, as far as I know. So we need to develop a new mechanism. And, sir, the IPAB, while the goal is right, the method is wrong. And so we would support, we'll work with you to develop something that really will bend the cost curve, really will achieve those spending targets, but to do so in a fashion that could actually work.
Thank you. Ms. Morrow, how could the IPAB affect the development of newer treatment modalities for prostate cancer as they're developed in the future? Does the IPAB have the potential to limit care for future patients as well as current patients, in your opinion?
Yes, we do believe that, IPAB is charged to reduce excessive growth rates in Medicare spending, and, that could be defined as reducing payments for new high-priced drugs, and we're very concerned about that, particularly in prostate cancer.
Thank you. The chair yields to Mr. Pallone for 5 minutes for questions.
Thank you, Mr. Chairman. I wanted to ask Dr. Lewin, one of the many ideas put into place by the Affordable Care Act was the Center for Medicare and Medicaid Innovation. It's a new effort by CMS to research and develop ideas to save money and improve quality in Medicare and Medicaid more quickly than before. Last week, the Innovation Center announced projects to improve the coordination of care for dual eligibles, for instance, in cooperation with the states. Do you believe that the Innovation Center is a good idea? Would you just, comment on it and why you might think that it's a good idea?
We heartily applaud the Innovation Center idea. We think that this is exactly what we need. And we need a part of the CMS agency that really starts rewarding and funding innovation and new ideas. I mean, we want to continue to have the best health care for all people in this country, and including those who don't have access right now, and we want to continue innovating. But we're going to have to cut spending. Fortunately, there's a lot, we can do this because there's so much waste in the current healthcare system. The Innovation Center moving toward the triple aim, things that improve health care, and lower costs at the same time are possible. The door-to-balloon, the speeding up of heart attack treatment is an example, and I could give you numerous more that we're working on in cardiology. So if we could start funding models and show people out there what best practices are, and then diffuse those across the healthcare system with a new kind of payment incentive process, I think we can solve this problem, have the best healthcare system in the world for real, and do it at GDP plus 1%.
Thank you. Did you want to comment, Ms. Creeley, on the Innovation Center as well?
I think this is a real opportunity for a public-private partnership. I think Jack has given some great models of what is being done in the private sector now against the financial incentives in the current Medicare program. They're doing the right thing despite not really getting rewarded for it. The value compendium that we have submitted will show you other examples of that. So I think it's an opportunity for the Medicare and Medicaid programs to learn from the private sector and to test pilot these things, as opposed to this board of 15 people coming up with a number, making some recommendations that perhaps haven't even been test piloted. And I think that's the real advantage of having the Center for Innovation.
Thank you. I was going to ask you also, Ms. Greeley, this is a quote from the CBO analysis of the Republican plan for Medicare and Medicaid, in their budget. It says, under the Republican budget proposal, the gradually increasing number of Medicare beneficiaries participating in the new premium support program would bear a much larger share of their health care costs than they would under the traditional program, and that greater burden would require them to reduce their use of health care services, spend less on other goods and services, or save more in advance of retirement than they would under current law. Now, in your testimony, you said that the IPAB, and I quote, IPAB has the potential to cause serious harm to Medicare beneficiaries, and but could you lend your, I'd like to know what your views would be of the Republican budget plan and its effect on beneficiaries. Do you agree with the CBO's characterization of the Republican plan?
The Healthcare Leadership Council for over a decade has supported the concept of moving to a premium support model for the Medicare program to give seniors more choice to have those private plans competing, much as they do in the Medicare Part D program. I think what we need to do is to look at the premium support model. There are many components to it. We probably would recommend using a different inflation factor. Much like Alice Rivlin, we would probably recommend maintaining for a period of time the traditional Medicare program. So I think there is a lot of merit to the concept. I think there's some modifications that we would make to the proposal that was put forward.
Thank you. Let me ask, I guess I have another 50 seconds here. I wanted to ask Ms. Morrow, again, you've made your concerns about IPAB clear, but as you know, this was developed as a backstep mechanism to address the growing cost of health care. And the Republican approach in the budget is very different. They would simply slash existing programs. They would end Medicare as we know it, and they would slash medical research. And I'm concerned about the impact on medical research of the Republican budget. The NIH budget was actually cut under the continuing resolution for this year, and for 2012 it doesn't look any better. If NIH, if you would just comment on it, I mean, I'm just concerned where are we going with research, with what happened with the CR and what's in the Republican budget for the future.
Yeah, continuing research in cancer is extremely important to us, and we do advocate for increased funding for research. And I'm not familiar with everything that's in the Republican plan, but I mean, we will continue to support more increased funding for research.
Okay. Thank you very much. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. Recognize the Vice Chairman of the subcommittee, Dr. Burgess, for 5 minutes.
Well, thank you, Mr. Chairman. And I thank you all for being here. This has been an interesting, although, Dr. Vlatka, you are correct that this was what did you call it, the IPAB-alooza? IPABulous?
IPAB-a-thon, but
IPAB-a-thon.
IPAB-alooza applies as well.
I do so welcome the comments of all of you. I think they've been very helpful. Ms. Greeley, I hope that you will take some time and take the Secretary of Health and Human Services perhaps to lunch and explain to her what premium support actually is. You might even want to include Ranking Member Waxman in that discussion, because he seems to have some difficulty, and even the President of the United States required a little remedial education on the difference between a voucher and a premium support system. Dr. Vlatka, let me just ask you, we hear a lot about the IPAB, we've heard a lot about it today, but I get the general impression that doctors and patients and patient advocacy groups do not support the IPAB. Is that a fair assessment? And if that's fair, why do you suppose that is?
To borrow a line from a high-ranking member of this body, when the healthcare debate was going on a couple years ago, you have to pass the bill to find out what's in it. And
now we know.
I think now that I've had that same conversation with many of my colleagues in the operating room, in the ICU, in the hallways, where they don't really quite know what IPAB is. And the more you talk to them and educate them, I don't think anyone thinks it's a good idea. And I think it's been gratifying to see this started as a very obscure issue that only policy wonks knew about, and now you're seeing it discussed in New York Times, Wall Street Journal, CNN, mainstream media outlets like that. So I do think that the more people learn about it, the less they are going to support it.
I think that's in general true. Now, Dr. Lewin, you talked about repeal the SGR before you do the IPAB. I got to believe that really you're the membership of the American Association of Cardiology would, or the American College of Cardiology would not support either of those control mechanisms. Is that correct? Now, the AMA did during, unlike Mr. Pallone, who voted for that bill, I voted against it. I thought the AMA was wrong to support it. What does your membership say?
Well, we certainly don't have any affinity for the SGR. It clearly doesn't work, and it's too bad we didn't deal with it 10 years ago, right? We all wish we had. That,
I wasn't here then.
Said, I think what we have to, the IPAB as it's currently designed, we don't believe will be effective in any way, shape, or form. It's going to be another price control mechanism. So we would like to get on with the challenge that we have as a nation of creating the healthcare system of the future that provides access to everybody, that continues to reward innovation and improve quality. And we think we need a different approach than the IPAB.
Well, let me tell you the problem, though, because you referenced the SGR and your pessimism that the SGR, that anything meaningful will happen. I actually, this year, I'm more optimistic that something's going to happen to the SGR than any time previous in my 9 years here. But here's the deal. You're exactly right. What if in 1998 someone had the courage to say, oh, this SGR thing is going to be a disaster in 10 years' time, and I'm going to fix it? Well, we have that opportunity with the IPAB now. Once the IPAB begins that cumulative effect of the dollar, the specious thing of the dollar saved, then there's going to be a CBO-directed cost associated with its repeal. And it won't be too terribly long before that cost becomes a mountain too tall to climb, just as the SGR is today. So, yeah, we've got to kill one that's mature, which is the SGR, but the other one, we do need to get a handle on it before it ever gets out of the box. And I would say the time is now to repeal the Independent Payment Advisory Board, and I'd encourage Mr. Pallone to join with us on that, because once this thing gets away from you, it's Katie bar the door. It'll be impossible to undo it. And I think, honestly, that's what the administration is banking on. They want to get this thing up and running, and it is another method. Let's be honest. This thing was not about health care, never was. It's a tax bill. But bottom line, it's about control. They want to control you. They want to control Dr. Volodka. They want to control what you do. They want you to do only what they tell you you can do, and they want to be able to tell you when to stop. Don't do any more. That patient's had enough. That's where this thing is going. Ms. Morrow, let me just thank you for being here. I don't have a question for you as relates to the IPAB on prostate cancer, but I do remember in the discussion of healthcare reform as it was going through, I read somewhere where some healthcare thinker said, we'll be able to tell if the Congress is serious about reforming healthcare as to what they do with prostate cancer, because the implication was we overtreat prostate cancer in the United States of America. However, recent studies comparing survival rates with prostate cancer in the United States versus Europe, it's like 99 versus 77%. I'd rather be here with all our faults than anywhere else in the world. Do you have any comments on that?
I've seen those same statistics, and as far as overtreatment, we strongly disagree with that term. It's up to the patient. The doctor and the patient can have an informed discussion about that person's prostate cancer and whether it's going to grow and affect them in their lifetime, but the decision should be between the patient and the provider.
And not the IPAB and the provider.
Exactly.
Thank you.
Chair thanks the gentleman and recognizes Dr. Cassidy for 5 minutes.
Dr. Volodka, a friend emailed me and said, how come you don't have a practicing physician on the panels? One passionate about our practices. And so I'll have to email her back and said, although I didn't pick it, we have one. My question for you is that when you look at the CBO score that Mr. Pallone referenced, it says the reason that traditional Medicare scores less than a private insurance plan is that traditional Medicare pays physicians less. Indeed, the way CBO scored it is although they don't assume the SGR cuts go through, they also have no inflation adjustment. Now, that's been the case since 2002, and effectively Medicare is paying physicians significantly less now than they were in 2002. So much so that Richard Foster says that within 9 years, Medicare will pay less on average than Medicaid. You are a practicing physician. Secretary Sebelius avoided answering this question every which way. But if Medicare is now paying less than Texas Medicaid, what will that do for access to services for those who have Medicare?
In one word, cost shifting. As we discussed here earlier today.
Now, let me say this. You're saying that as a specialist who sees people coming through the ER and almost have no choice but to see the patient. So speak first as a specialist and then imagine what it would do for access to primary care.
Well, exactly. As you well know, when patients come through the emergency room, we take care of them first, and oftentimes we don't even know their name. You know, they're in a computer's unknown number something. We operate, we take care of them, and then later figure out who they are, who the family is, you know, if they have any resources. That's a hospital administration issue. But that's time it takes away from your practice, and as you know, time is a very precious thing. So you're going to have to make up the gap in other ways because you're going to have to pay your secretary, your nurses.
You have a fixed overhead.
Absolutely.
Now, now knowing that you're not primary care, but if you're primary care and you're spending 50% of your receipts on fixed overhead, and you've got a choice of which patients that you can afford to take. New York Times documented this very well. An oncologist in Michigan getting paid below cost by Michigan Medicaid at some point can no longer afford to take more Michigan Medicaid patients. Would you accept that it's going to hurt access to primary care?
Well, I think you used the word choice as to what patients you're going to have to take, and I would quibble with you a little bit. You don't have a choice. You have to take more patients with commercial insurance just to subsidize all the activity you're spending taking care of the patients with no insurance or Medicaid.
Or limit what you would take. Now, in this case, if Medicare is paying less than Medicaid, we would now put the Medicare patient in the same boat, if you will, as that Michigan Medicaid cancer patient who could not find a provider.
That's exactly right.
Yeah, and again, in 9 years, under the provision that CBO describes as saving money for traditional fee-for-service Medicare, we in Medicare as we know it, because seniors will not be able to access care. Dr. Lewin, you raised something, just kind of I'd thought about it, but the way you phrased it kind of ticked my mind a little bit. So IPAB can only cut among providers, physicians.
No.
So really, we could have a hole in the bucket for Medicaid, for hospitals. There could be a hole in the bucket for hospitals, just inordinate amount of cost going there. But physicians would have to make up the difference, correct?
As it is now, yeah, because hospitals have I think till 2018 or 2019, yeah, they're out of the loop. They kind of negotiated themselves out. I just can't stress it enough. It's like a broken record. We have to do something different than this. We need to deal with the rising costs of Medicare. We can, but we need help from Congress to do that with a different approach than this design. This isn't going to work. And if this is health reform, let's start off and do something the right way, and reward the incentives for quality and efficiency and improve care. That we can do. We now have the tools to do that. We couldn't have done that in the 90s when health reform was proposed. We can do it now, and physicians want to do this. We still want clinical judgment's still going to be important, and we want to protect the patient-physician relationship in this process.
I like the way you emphasize the practicing physician's role in controlling healthcare costs. I note in IPAB, I don't think you're allowed to continue to practice and still serve on the board, which gives me kind of pause. Wait a second, if the person who's in the mix, if she is the one who knows best how to do it, but she's the one who by statute is not allowed to serve, it seems kind of odd.
Certainly, especially a full-time occupation to be on the board. We're going to attract people. They're going to be retired people. Right. So this is not designed for a system that's really going to innovatively improve Medicare.
It was a system designed by staffers, not by people involved in healthcare. I am out of time. I yield back. I thank you all.
Thank you.
Chair thanks the gentleman. That completes the first round. We'll have one follow-up on each side. Dr. Burgess.
Dr. Lewin, you referenced that the setting price controls on volume doesn't work, and I think we've seen that with the SGR rather eloquently. You reduce the amount you pay, and you drive up volume because, as Dr. Cassidy pointed out, overhead costs are fixed. So you got to do more if you're going to keep those overhead costs met and continue to earn a salary if you're in an individual or a small group practice, which I was. Now, fee-for-service medicine gets a bad rap in all of this, and we are told by all the great thinkers in healthcare that the fee-for-service system is the culprit. But really, the culprit is the administrative pricing brought to us by the Center for Medicare and Medicaid Services. And in your specialty in particular, I mean, I have had deans of medical schools who are cardiologists come to me and say, the big problem is the overutilization of our specialty. You know, the door-to-balloon time studies that you've done, that's great and a great metric, but if these guys are accurate and more balloons are being done than are necessary, then it doesn't matter that you do them quickly. It's still going to be a cost driver. And yet, because of administrative pricing, we have favored that type of activity in the Medicare system. You know, you'd ask yourself, the big problem that everyone talks about is childhood obesity. You got the First Lady working, you know, that's her main cause. You would think that with childhood obesity and the raft of childhood diabetes that will follow, that we would be churning out pediatric endocrinologists right, left, and center, and yet we turn them out a handful a year. And cardiologists, though, we turn out a lot. So how, as the leader of your professional organization, how are you proposing to deal with this? Forget STR and IPAB for a moment. You guys have a responsibility here.
Yeah, you know, just as a quick aside, that with the tsunami of obesity and diabetes, there's not going to be, well, we won't have enough cardiologists to deal with what's coming up in the future. But you know, we really have we have the tools now to make sure that people who have chronic stable angina, who are approaching the system for care, don't get a stent when it wasn't really needed, or don't get bypass surgery where a stent would have been better, or get to optimal medical therapy when the data shows that the results will be better and they'll have no risk of complications in the meantime. We have these tools, we have the science, but there are no incentives to apply them in hospitals across the country. We have incentives to reduce the use of implantable defibrillators for people for whom the science says they shouldn't have gotten them. We published it. We published our data. We have 100%, thanks to Medicare requires the use of our registry. We have 100% of the implantable defibrillator data in the United States. We pointed out 23% of them apparently were placed without the best guideline evidence being present. Now, we want to go around and educate everybody, but the incentives are not there to say to the hospitals and the doctors, we're going to reward those who start to reduce that variation, not pay for the volume.
Well, how will IPAB reduce that variation?
It won't. It will not. IPAB has no way to do that. We need a different mechanism, and that's payment incentives for improved quality and outcomes and efficiency. And measure, you have to measure to manage. So you've got to have systems out there to give doctors and hospitals feedback, dashboards of feedback on how they're doing as compared to all their peers. When they have that information, they will change.
Dr. Vlaka, let me just ask you, you're the only practicing physician that we've heard from all day. What about how does medical liability reform factor into what Dr. Lewin was just talking about?
I think liability reform is a huge way to try to bring down cost in the healthcare system. Now, it's not part of IPAB, of course. We may be getting far afield, but you're a Texan. You've heard about the Texas miracle. And following tort reform there in 2003, it did everything that its proponents said it would. It lowered the cost of professional liability insurance. It brought more PLI carriers into the state. And most importantly, it brought a lot more physicians into the state. And those guys are going to the rural and underserved areas just as much as going to the major metropolitan centers. The only downside has been the flood of applications of Texas medical boards.
Yeah, the Texas medical board's in trouble. But Dr. Lewin referenced, the fact that sometimes a stent might do instead of a bypass or maybe maximal medical therapy. But it can be tough if you're the doctor on the front line who is worried about the appearance of, did I do everything possible if this patient walks out of the office and crashes and burns in my parking lot? Did I do everything possible to prevent that from happening? And that is a burden with which we live as practicing physicians every day, is it not?
Oh, that is absolutely true. And to put that in perspective, that is going to happen a certain percentage of the time, even if you do everything right. So now you're thinking, okay, did I do everything right? Someone's going to be looking over my shoulder in 6 months or 12 months if there's a bad outcome. And again, Abraham Lincoln said that even if you did everything right and events proved you were wrong, 1,000 angels swearing you were right will make a difference. So that's a huge concern for all practicing physicians.
Thank you for being here today, all of you. Thank you.
Chair thanks the gentleman and recognizes the gentleman from Michigan, the ranking member emeritus, Mr. Dingell, for 5 minutes of questions.
Mr. Chairman, you are most courteous. Thank you. Dr. Lewin, welcome to today's hearings. I'd like to begin to discuss your recommended improvements to IPAB. You mentioned in your testimony that flexibility should be provided to help recruit high-quality board candidates. Do you believe then that under the current statute, the board will be unable or will be able to recruit high candidates?
Congressman Dingell, thank you for the question. I don't believe the way it's currently constructed, the IPAB will recruit the kind of people that we want. First of all, the IPAB membership is a full-time, if you will, occupation. It means that we can't bring in the best and the brightest from throughout the health sector with various perspectives to help guide this process. We're almost destined with that approach to bring in retired people.
My next question is you've gotten a bit ahead, but one, what will be the barriers to recruiting candidates? And two, what should we do to eliminate those barriers to enable us to recruit the strongest candidates?
My guess is that the importance of this process is that there's some excellent candidates may come to serve just with their expenses covered. But I think that this shouldn't have to be a full-time commitment on the part of those individuals. We need people who are the best and the brightest in the healthcare sector, who understand the economics as well as the clinical realities of this and the patient perspective part of this, to be sitting at around this table. So I think that the way it's designed in terms of the pay and the requirement that it be a full-time occupation will make it very untenable.
Okay, now, Dr. IPAB establishes a consumer advisory council to advise the board on how payment policies impact consumers. However, this is an advisory capacity only and does not include patient representation. Now, as a physician, how would you recommend addressing this problem and encouraging patients' participation to help in decision-making necessary for the board to issue the best recommendations?
Well, I think the IPAB ought to have patient representation sitting right there on the board itself, if it was to exist. Patient representation should have been part of the process of the IPAB. But I would say, Congressman Dingell, that I think we have to reconstruct what we consider this IPAB model if we wanted to actually achieve cost containment over time by systematic improving quality of care. I think the way it's designed isn't going to work, so I'm not so concerned about how we get the members on it right now. I'd like to see a design of a system that might actually reduce costs and improve quality.
I notice you, Dr. Velasquez, were nodding yes.
Yes, I agree completely. It seems like we've gotten a little bit ahead of the conversation. We're talking about how to structure IPAB and how it should be set up with advisory committees, but I think a more fundamental question is really, will it achieve the aims it sets out to do without creating too many adverse events like limiting access to care for our seniors?
Thank you. Now, again, coming back to our first witness here, your testimony suggests the use of data registries is one way to ensure high-quality care while identifying areas to reduce spending. In particular, Doctor, you mentioned the ACC's Pinnacle Outpatient Registry. I happen to believe that the technology advances like electronic health records and registries can create savings, but also know that there can be a resistance to implementing such technologies. How many providers participate in this registry currently, Dr. Lewin?
Thank you for that question, Congressman Dingell. Nearly all the major hospitals in the United States participate in the registries, and they pay us for the data, and that allows us to actually keep this very expensive operation going. In the physician outpatient setting, it's really hard to ask the doctors to pay us for a collection of data at this time, but 1,000 practices have signed up. We have 2 million patient records already with this relatively new system, and we can see measured improvement in quality across the entire Pinnacle network. I might add that 100% of the Pinnacle participants received the full PQRS reward and the e-prescribing reward, and we were able to file for them. So there is some small reward, but if we were to use payment reform to provide real incentives for improved outcomes and quality, this would go rapidly across the entire environment. It needs to reach to internal medicine and family practice and others who share in the care of cardiology patients with us in the outpatient setting.
My time is up, Doctor, but I'm with the patients as a chair. I'm going to ask you, can you give me an example of how a member of ACC has used the registry to bring down the costs of their practice?
Impasse of having to go through call a nurse to get permission for a procedure because they can demonstrate to the insurance company that they're making the right decisions using the clinical decision support tools embedded in the registry. So it's a hassle factor improvement for the doctor, and time is worth money. So even though the payment incentives aren't really aligned yet to improve quality, even now this Pinnacle registry is offering some benefits to people in the current environment.
Thank you, Doctor. Thank you, Mr. Chairman.
Chair, thanks to gentlemen. We are voting on the floor. We have 11 minutes to go. We have time for follow-up from Mr. Pallone.
I'll be quick. I know that both Dr. Burgess and you, Dr. Lewin, brought up the SGR, and I do think that certainly when I hear from the doctors, they see the SGR and again the cliff we faced in January as the biggest threat to Medicare, more so than IPAB. And I'm opposed to IPAB, but I just wanted you to comment on that. I mean, isn't this SGR a major threat, more so than IPAB? And what are the doctors telling you about it?
We'd have to think that it's a major threat. It's certainly a threat to access. If more doctors can't afford to accept Medicare patients, clearly it's going to pose a nightmare for our healthcare system, for emergency rooms, and for the entire system. So we are very, very worried about it, and particularly because it's a big price tag to try to fix it, and we don't know how. I honestly don't know how it's going to happen, given the conversation on the debt ceiling and the deficit. So I assume we might end up kicking that can down the road again, and I'm very, very worried about that. Much more worried than I am about the IPAB.
Well, I just wanted to say I know that Dr. Burgess mentioned that he hopes that we can get to it and do a long-term fix this year, and I'm very much supportive of that. I always kid him because he was I think the only Republican who voted for the Democrat long-term fix that we passed a couple of years ago. So I have to commend him for that, although maybe he doesn't like to be commended for that. But I would just ask, Mr. Chairman, that I know that we've already had a hearing on it, but I would urge that we do try to address it and not wait till the last minute and kick the can down the road. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. And for the information of the panel, we are going to deal with the SGR this year. We intend to do a long-term fix. We're in the process. We've collected information from all the doctor groups. We've had many meetings, and we're in the process of developing a vehicle, but it'll probably be after the break in the fall that before we get to it. But we intend to deal with it on a permanent basis before the end of the year. With that, this has been an excellent panel. Thank you for the information you've shared. That concludes today's hearing. I remind members that they have 10 business days to submit questions for the record, and I ask the witnesses to please agree to respond promptly to these questions. With that, the subcommittee is adjourned.